All right, we'll start. Is anybody not here? You're all here? Okay, let's do drug toxicities on page 26. Bad news, you got to know your drug toxicities. Good news, you don't have to know them all. You just need to know what everybody else knows. And if anybody knows drug toxicities, they know these 5. Anything beyond these 5 is really nuts to know. It's not really need to know territory. You do need to know these 5 though. I would really suggest that this is a little bit of memory work, but it's a good payoff for it. Because you understand this is a test for nurse safety, and one of the biggest ways you can be unsafe is to not know drug toxic effects. Do you see how that could result in real patient harm? So that's an area they like to test, is toxic reactions to drugs, drug toxicities. So let's talk about these 5. Lithium. Lithium, of course, is the famous anti-mania drug. It's used for bipolar, but it's not used for the depression. It's used for the mania. Its therapeutic level in the middle column there, you should write 0.6 to 1.2. Now the toxic level is greater than or equal to 2. Now immediately you should see that there is a gray area there where you're higher than 1.2 but under 2.0. Do you see that gray area? That is a gray area where no books agree on exactly what's going on with lithium at those levels. From 0.6 to 1.2, everyone agrees that it is therapeutic. Everyone agrees that 2 and over is toxic. But in between, you just pick your book and they're going to say different things. One of the things that you guys don't know about me, well maybe you do know about me, that probably is good for you to know about me to help you understand why I say what I do and how I say what I do, is that for years I was a NCLEX RN item test writer. I wrote questions on the NCLEX. So the questions that were on there, I've written some of those questions. So I've been through the whole training protocol on how they want you to write questions for them. So when I tell you that questions are written this way, that's because I've been through the in-service education on it, and I've been trained as their item writer. In 2003, I think it was, maybe it was 2002, somewhere right around in there, the NCSBN made a rule that you cannot be an item writer and be a NCLEX reviewer at the same time, which makes sense. You can't write the questions and then go teach people how to pass the test. It's not ethically correct. So at that time, I had to pick between writing questions and reviewing, and I picked reviewing, and so I stopped writing questions. And so I haven't written a question since 2003, roughly. But if they only change 5% every year, there's still loads of questions on there that I've written. Now, I say that to tell you that when I give you ranges, the ranges I give you may not be the ones you learned, but they are the ones that you use when you write questions. Do you see what I'm saying? And most of the time, my ranges are wider than what most of the times than what you learned. Because the instructions are to every item writer on the boards is when you write a test question that where you use a lab value or a range, a value in a range, a number, go to at least 5 different books published by 5 different publishers and see what they say the range is, then make your range wide enough to fit all of those. Do you see what I'm saying? So if book 1 says 1 to 2, book 2 says 1 to 2.3, book 3 says 0.8 to 1.9, well, you got to go from 0.8 to 2.3 as your range. That way it's a fair question no matter what book the students used. So you're going to see my ranges are different, but my ranges are made to fit the NCLEX. Do you understand that? And not necessarily a particular book. So you may use my ranges and my numbers, and you may go take the like the Saunders review book with questions, or the exam cram with questions, or the NCLEX Gold with questions, and using my ranges, you may miss the question. Why? Because they went by their ranges. What ranges? The ranges in the MedSurg book that company publishes. Only one book, not 5. Now, Kaplan does what I do. Anybody that's a national reviewer does what I do, which is a wider range than normal. Okay? So here's the deal. Boards would never give you a lithium of 1.3, 1.4, 1.5, 1.6, 1.7, 1.8, 1.9. Why? It's in that gray area where books don't agree, and item writers have to get it to where all the books agree. So I teach you 2 and greater because every book agrees that is toxic. Alrighty? So don't worry about that when you see these ranges. Okay, Lanoxin. Lanoxin, what's the other name for it? I told you yesterday you have to know this. DIG. This is used to treat basically 2 things. DIG is used to treat AFib and congestive heart failure. Atrial fib and congestive heart failure. How should you have already known that it treats atrial fib? DIG. In what context did we talk about DIG yesterday? Adena, beta, calcium, DIG. Oh, so DIG is the D of the ABCDs of atrial treatment. So atrial fib, yes. And then congestive heart failure is the other big one that it treats. Well, what is the therapeutic level of DIG? 1 to 2. And you notice I'm not giving you units, correct? Because what did I tell you about units? Don't worry about it. They're not going to ask you. They're going to say, how many milligrams per deciliter of? And you just say the number. Its toxic level is greater than or equal to 2. So what do you notice about 2?
Therapeutic range.
It could be therapeutic and it could be toxic. So what do you call it when they give you a value of 2? Toxic. Why? It's safer to call something toxic when it may not be than to say it's therapeutic when it might not be. So always err on that safe side. What do you notice about lithium and lanoxin's toxicities? They're the same at 2 and greater. Aminophylline. Aminophylline is a airway antispasmodic. It relieves spasms in your airway. It is technically not a bronchodilator. What do I mean by that? It is technically not a bronchodilator. What does it not do? It doesn't stimulate your beta-2 agonist cell to bronchodilate. It just relaxes a spasm. Now, when you're in a spasm, your airway's what? Narrow or wide? Narrow. And when I relax a spasm, what happens to the airway? It gets what? Wider. So it actually looks like it's a bronchodilator, but it's not really a bronchodilator. Epinephrine's a bronchodilator. You know, ipratropium is a bronchodilator. Albupen, albuterol are bronchodilators. Terbutaline is a bronchodilator. This is a muscle spasm relaxer. Has anybody ever, and I'm sort of just going off the side here on these things just to see if you can apply some stuff. Have you ever seen anybody come in or heard of anyone coming in an acute asthmatic attack and the bronchodilators aren't working? That happens on occasion. Probably what's happening. Why aren't the bronchodilators working? What's that? I really can't hear you unless you talk. Okay, the inflammation, but there's a bigger reason. They're in a spasm. They're in an acute lockdown spasm. And the bronchodilator isn't going to work because the spasm's in the way. So what do you have to give them first? Some aminophylline to do what to the spasm? Relieve the spasm. Then you can come in with a bronchodilator and it will work. So just remember, when a bronchodilator doesn't work in an acute airway problem, give them a theophylline, give them an aminophylline, and that'll melt the spasm, and then the bronchodilator will work. Yes?
Do they have protocols then where they give the antispasmodic first versus the
Yeah, a lot of times when little kids come in with acute reactive airway disease, they'll slap them on an aminophylline drip and then start giving them breathing treatments with betas. And they may have 20 of them. And the first 19 may not work until that aminophylline kicks in, then the 19th one works. You see? So I've seen little kids. What's the most breathing treatments you've seen airway? Anybody ever in work ER in children's stuff ever? Or what's the most? Nobody's? Okay, well then it's a dumb question. But I have seen up to 20 breathing treatments being given in a row to these little kids. It's really just phenomenal. Okay, that's not typical. That's the extreme. All right, what's the therapeutic level? 10 to 20. There again, don't worry about units. 10 to 20. Any aminophylline under 10 is what? If you get an aminophylline level of 8, what's that mean? So they need to take more. Or are they taking it? Okay. If it's 21, what's it mean? It's toxic. But anything in between 10 and 20 is therapeutic. What if it's 20? Because 20 toxicity is greater than or equal to 20 on this one. So 20 could be either way, so you call it toxic if you have to. So aminophylline toxic is greater than or equal to 20. Dilantin, what is this used for? Does anybody know what dilantin or phenytoin?
Seizures.
Seizure, yeah. Its therapeutic level is 10 to 20. And its toxicity is greater than or equal to 20. So what do you call 20? Although it may be therapeutic. Bilirubin. Bilirubin is not a drug. It's a waste product from the breakdown of red blood cells. When boards test bilirubin, they will only test it in newborns. They will never test it in adults. Does anybody know what the normal adult bilirubin is? It's like 1 to 2, 1.4 to 2.3, something like that. It's really low. But in newborns have high bilirubins all the time. Why? What are they doing? Breaking down which red blood cells? The moms. So babies will run bilirubins of 5, 6, 7, 8, 9, and that's fine. Now, if I had an 8 bilirubin right now, they'd have my rear end in a bed over there finding out what's wrong with me. But a newborn with an 8 is no big deal. So what I want you to do with this bilirubin is, do you see where it says therapeutic level, the middle column? In the box for bilirubin, I want you to write the word elevated level. Elevated level. So what is the elevated range for bilirubin in a newborn? 10 to 20. So what does it mean when a bilirubin in a newborn is 9.9 and less?
Normal.
It's normal, but it's
Still high.
It's high for an adult, but it's normal. So we don't even get concerned about newborn bilirubins until it hits what number? 10. Which is 5 to 10 times more than what an adult should have. So what is the bilirubin toxicity? Greater than or equal to 20. So when do you suppose a child with what bilirubin and above do you think needs to come into the hospital?
or above?
Certainly before, what about before 10?
No.
No. And even at 10, 11, and 12, what are they? Is it elevated? But you can manage it at home with sunlight, drinking a lot, flushing that bilirubin out. It's usually right about 14 to 15 that docs start thinking about hospitalizing these kids. About 14 or 15. Because once you hit 15, where are you in the scheme of things overall? You're halfway to what? You're halfway to toxic. And once you hit toxic, they can die. So you don't want it to be 18 or 17 or 19. That's way too close. You just don't like that. So, but most docs will not bring in a 12 or a 13. They'll usually wait till 14. Some docs wait till 15. I don't see any docs that wait till 16. I just typically not. Okay, so halfway through the elevated range, they start to hospitalize. Now, what do you notice about those toxic levels? What pattern do you see? 2s and 20s. 2s and 20s. Which ones are the 2s? Lithium and linoxin. We start with what letter? So you pick the lower number with the ones with L. So lithium, linoxin go low. 2. Bilirubin, aminophylline, dilantin go high, go 20. So you're usually picking between 2 and 20. And those are the major ones that they talk about. All right, what about kernicterus and opisthotonus? Do you see those words right there? You need to know these words, these vocabulary words. What does kernicterus mean? Does anyone know what kernicterus means? Bilirubin in the brain. When your bilirubin crosses your blood-brain barrier and it's in your cerebral spinal fluid, it's in your brain, it's in your meninges, you have kernicterus. So kernicterus, okay, what's jaundice? It's a yellow color due to
Too much bilirubin in the blood.
bilirubin in the
Blood.
skin. What's kernicterus? Bilirubin in the
Brain.
Do you see what I'm saying? So jaundice is bilirubin in the skin. Kernicterus is bilirubin in the brain. Both are due to bilirubin. It's just where is it? Kernicterus usually occurs when you get up around 20. When your bilirubin gets around 20, you start going kernicteric. Do you see why it's so dangerous? Because bilirubin, when it gets into your brain, it causes what we call aseptic. What does that mean? Aseptic. A means what? Without. Sepsis means infection. So aseptic means no germs. It causes aseptic meningitis, aseptic encephalitis, which means a sterile encephalitis due to the irritation of the bilirubin. You don't have to know all that. Just know that when your bilirubin gets to be 20, you go kernicteric and you could die. The baby could. Now, opisthotonus, does anybody know what that is? I told you we'd learn a lot of vocabulary this week. What's opisthotonus? Okay, it's a position the baby assumes when they have bilirubin on the brain. It's a position. Kernicterus is a condition. Opisthotonus is a position. And what they do is they hyperextend. These babies hyperextend due to the irritation of the meninges with the bilirubin. So these babies hyperextend. Now, what do you know about the flexibility of a newborn? No flexibility or unbelievable flexibility. Unbelievable. So when they extend, literally their heels will come up and touch their ears. They will be like in a back walkover. They'll be completely, and they'll be very rigid in that. They'll hyperextend. They almost look like they're decerebrating, if you've ever heard of decerebration. They're real hyperextending. When you see that, when you see a little kid whose bilirubin is 15, okay, kid came in, bilirubin 15, and he starts extending his neck, what do you think? Is that something that needs followed up right away, immediately, medical emergency? Yes, because he could be going into opisthotonus because he's kernicteric. And you want to catch it right away. Now, the question that often is asked on boards and other standardized tests is, in what position do you place an opistotonic child? Now think about it. If they're hyperextending like this, what's a good position to put them in? On their side. You can't put them on their back. You can't put them on their abdomen. You have to put them on their side. Okay, that's it on drug toxicities. Just remember your 2s and your 20s. Yes?
Does bilirubin, they don't test based on how many hours in the morning, how many days on the boards?
Well, the only thing boards will do there is they'll talk about pathologic jaundice versus physiologic jaundice. And physiologic jaundice, the bilirubin is high and the kid is yellow at birth. With pathologic jaundice, no, reverse that. Pathologic, it's high at birth and the kid's yellow at birth. Physiologic jaundice, the kid's bilirubin is low at birth, normal at birth, and over the next 2 to 3 days goes high on bilirubin. So here's the deal. If they come out yellow, something's wrong. It's pathologic. If they come out yellow. If they turn yellow over the next few days, that's typical, expected. But they're just going to ask about whether it's present at birth or develops on day 2, day 3, and which one's pathologic, which one's physiologic. And they won't get any more specific than that. Which is in the blue book, so you got to remember that blue book too. Okay, dumping syndrome versus hiatal hernia. These are very commonly tested things on boards, particularly dumping syndrome. They really like to talk about dumping syndrome. It shows up a lot. Definitions. What is hiatal hernia? Well, I like to talk about these two together because they're both gastric emptying problems. And they're kind of opposites. And I like to remember opposites together. Why? Memorize one and you got the other. That's why diabetes insipidus and SIADH, I'm only going with one, figuring the other one out. Well, let's talk about what hiatal hernia is. Hiatal hernia is regurgitation of acid, meaning acid comes back up into your esophagus where it's not supposed to be, because the upper part of your stomach herniates upward through the diaphragm. You're not supposed to have, your stomach is supposed to be 100% in your abdominal cavity, right? With hiatal hernia, you have a 2-chambered stomach. You're like a cow. You got 2 stomachs. Typically, this is your thorax here. Okay, and here's your diaphragm separating your abdominal cavity below from your thoracic cavity above. Esophagus comes down like this, and then the stomach is there. It's supposed to be all below this diaphragm. In hiatal hernia, what happens is part of it goes up like this, and you've got a 2-chambered stomach with a band around the middle. And what happens when you eat, it sort of sits right here and then comes right back up. That's the problem with hiatal hernia. Now, below the line there, do you see where it says gastric contents move? Gastric contents move in the right or wrong direction? Wrong direction at the correct rate. In other words, does the stomach empty faster or slower or at a normal rate? Well, it empties at a normal rate. The rate's not the problem. With hiatal hernia, the rate is not the problem. It is the direction that is the problem. It's moving in the wrong direction at the correct rate. Now let's compare that with something called dumping syndrome. Dumping syndrome, again, is a gastric problem. It usually follows gastric surgery, in which the gastric contents dump too quickly into the duodenum. Now, are your gastric contents supposed to go into your duodenum? Yes. So what's the problem? It's too fast. So in this case, the gastric contents move in the right direction at the wrong rate. So you see where they're opposites? One is correct rate, wrong direction. The other is wrong rate, correct direction. They flip-flop. So if these were speeding tickets that if these were traffic violations you got, what would you be cited for in hiatal hernia? Going the wrong way on a one-way street, correct? What would you be cited for with dumping syndrome? Speeding. So one's a speed issue, one's a direction issue. All right, what are the signs and symptoms? Well, hiatal hernia is real easy. The signs and symptoms of hiatal hernia are just plain GERD. G-E-R-D. Gastroesophageal reflux disease. In other words, heartburn and indigestion, to state it simply. So when you see GERD, don't freak out. It's just heartburn and indigestion. No biggie. But let me tell you something. Hiatal hernia is a specific case here. You can have GERD for 100 different reasons, one of which is hiatal hernia. What makes GERD hiatal hernia is this. Hiatal hernia is GERD if you lie down after you eat. If you have indigestion and heartburn, it doesn't mean you have hiatal hernia. You could have it, but it doesn't mean you do have it. I'm going to give you 2 examples, and you tell me which one has GERD and which one has hiatal hernia. All right? A nurse gets up in the morning, skips breakfast, goes to work, passes a whole floor of meds, does a bunch of treatments, and at 11 o'clock gets epigastric burning pain, burping, indigestion, and it really, really hurts, and they gotta drink some milk or something, or this hurts. Do they have GERD? Yes. Do they have hiatal hernia?
No.
Why not? You aren't lying down and you didn't eat. Okay, but what about this patient? Nurse gets off at 7 p.m., goes home, eats dinner at 8 o'clock. Sits down, watches TV, half hour later eats a bowl of cereal. 20 minutes later eats a bag of chips. 20 minutes later eats, ice cream and chocolate syrup. Then they get tired, and 10 minutes later they go to bed. Half hour later they wake up with burning, epigastric pain, indigestion. They go, oh, it hurts. Same set of symptoms that the other nurse had. Could this person have hiatal hernia? Why? They lay down right after they ate. You cannot have hiatal hernia unless your symptoms occur when you're lying down after you eat. If you have GERD at a random times, you don't have hiatal hernia. Hiatal hernia is dependent upon position and meal time. That's hiatal hernia. It's just indigestion and heartburn when you lie down after you eat. Okay, dumping syndrome, and they like to test dumping syndrome, and it's a huge list of signs. The easiest way I know to remember all the things that happen in dumping syndrome is to take what I already know and combine it to equal dumping syndrome. So what do I want you to take? Well, first off, if you want to know what a person looks like with dumping syndrome, the first thing is talk about drunk. Okay, what's a drunk person look like? Staggering gait, slurred speech, impaired, judgment delayed, reaction time, emotional, what's the fancy word? Labile emotions. Well, all that can be dumping syndrome, because with dumping syndrome you do have cerebral impairment because of decreased blood flow to the brain, because all the blood's going to the gut because it dumped into the duodenum. Then you also get shock. Signs of shock, which are what? Hypotension, tachycardia, tachypnea. What's the skin? Pale, cold, clammy. Cold because you don't have any blood there. It's vasoconstricting. So pale, cold, clammy. All right, so drunk plus shock. What does that equal? What did I teach you that drunk plus shock equals? Hypoglycemia. Well, to get dumping syndrome, you add to that acute abdominal distress. And what belongs on the list of acute abdominal distress signs and symptoms? When someone has acute abdominal distress, describe them for me. Cramping, pain, doubling over, guarding, protecting. What else? What would you hear with a stethoscope? Borborygmi, thank you. Yes, hyperactive bowel sounds, but they won't say that. They'll say borborygmi. What kind of bowel elimination pattern would you have? Diarrhea. So you get cramping, abdominal pain with diarrhea, borborygmi, guarding, bloating, distension, tenderness. That all goes with dumping syndrome. So if you get a dumping syndrome question and they ask you for signs and symptoms, how do you learn them? Drunk, shock, acute abdominal distress. So here's what hopefully see, I want you guys to start filing things better, more efficiently. They do test alcohol intoxication, which is drunk, right? So drunk is drunk, right? You know that. Okay, shock, they'll test that too. Shock looks like shock. Do you understand this? Now, if you take drunk and shock and you put them together, what do you have the signs and symptoms of? Hypoglycemia, low blood sugar. If you throw in some acute abdominal distress with that, what do you get? Dumping syndrome. So I'm trying to link 4 of the major things they test. Shock, low blood sugar, dumping syndrome, alcohol intoxication. They all can be learned together. So what's the protocol? Drunk is drunk. Shock is shock. Drunk plus shock is hypoglycemia. That plus acute abdominal distress is dumping syndrome. And you're just, see what I'm trying to do is get you keeping adding rather than memorizing 4 separately. Okay, drunk is drunk, shock is shock, drunk plus shock is hypoglycemia, drunk plus shock plus acute abdominal distress is dumping syndrome. Okay, number 3, what's the treatment for hiatal hernia and dumping syndrome? They're going to be opposites. Because think about this. With hiatal hernia, you want the stomach to empty faster. Why do you want the stomach to empty faster with hiatal hernia? Because if it's empty, it won't what? Reflux. However, with dumping syndrome, we want the stomach to empty slower. Do you see it's the opposite? So if you just remember one, remember the other's the opposite. So what are you going to do to affect stomach emptying time? Well, there are 3 things you can do. To change the way the stomach empties, you can play around with the head of the bed, you can play around with the water content of the meal, and you can play around with the carbohydrate content of the meal. All right, so let's go through this. In hiatal hernia, what do we want to do with the head of the bed during and after meals? We want it in high position. Why high? That makes gravity empty it faster. Okay, go down the column. What do we want to do with the amount of fluids we give with the meal? Would a liquidy meal or a solid meal, which one will go through the stomach faster? Liquids. So we want the stomach to go through faster with this. So we want the amount of fluids to be high or low. So high fluid. And carbs go through you really fast. Carbs go through your stomach fast. So if you have a high carb, will it empty faster or slower? Fast. So here again, you want the carbohydrate content to be high or low? High. Now, the dumping syndrome is opposite of that. So how should a dumping syndrome eat their meals? In low position, head flat. In other words, how would they eat? How should they eat? Yes, head of the bed is what? Flat. They're turning to their side and they're eating on the side with the head down. They don't eat on the back with the head down. That would be stupid, right? But on the side with the head down. So low head of bed. What about the fluids with the meals? High or low? Low. So when would they get their fluids? Not with the meals. They'd get it, what, an hour or two before meals or an hour or two after meals, but they would never get it with the meals. And what about carbohydrate content? Low, because we want the stomach to empty slow. When everything is low, the stomach goes slow. Do you hear that? When everything is low, the stomach empties slow. In high aidal hernia, you want everything to be what? High. In high aidal hernia, everything needs to be high. So when you see high aidal hernia, you should say everything needs to be high. What needs to be high? Head, fluids, carbs. And if you want the stomach to go slow, pick everything low. Head low, fluids low, carbs low. Now be careful. What if they throw you a curve and they talk about protein in the diet? For these two. What do you think?
Or low and high already.
Yeah, low protein in high hernia, high protein in dumping syndrome. Because if you're low carb, you're going to be high protein. You understand that? So whatever carbs is, protein's the opposite. Any questions about dumping syndrome and hiatal hernia? They're pretty clear. This is a review, so sometimes people say, "Mark, I know most of what you're teaching me," and I say, "Good. This is called a review." So don't get upset when there's a lot of stuff you know. Get upset when it's all a news flash. Electrolytes. How many of you in here can give me 15 signs and symptoms of hyperkalemia, hypokalemia, hypercalcemia, hypocalcemia, hypermagnesemia, hypomagnesemia, hypernatremia, and hyponatremia with 80% accuracy? How many could do that? When you raised your hand, everybody in class went, "Oh, I'm not Derek." No. Anyhow, how many could do it with 50% accuracy? No. You probably wouldn't even be able to get 50 with your book. No, okay, what about 5% accuracy? Yeah, I got takers on that. Okay, I'm going to ask you that same question in 15 minutes, and I want to see what you say in 15 minutes, all right? So let's talk about electrolytes. To know your signs and symptoms of electrolyte disorders, you need to memorize 3 sentences. The first sentence you memorize is, kalemias, do you see where we're at? Number 1 here. Kalemias. What are we talking about? Kalemia. Potassium, yeah. Kalemias do the same as. Same as goes in the blank. Same as. Same as. The prefix, except for heart rate and urine output. Potassium imbalances do the same as the prefix, except for heart rate and urine output. You memorize that. Kalemias do the same as the prefix. So what I'm telling you is when you get a kalemia, just look at the prefix. There are only 2 options, hyper and hypo. Hyper means everything is what? High, and hypo means it's low. And your symptoms will go high with hyper and low with hypo. They'll go high with hyper and low with hypo, because it's doing the what? Same as the prefix. Except for the heart rate and the urine output, which will go what? Opposite of the prefix. So with hyper, urine output and heart rate go down, and with hypo, urine output and heart rate go yes. So in your box there, give me some signs and symptoms of hyperkalemia. Hyper. Okay, start with the brain. Give me some hyper signs in the brain. Surely you know what I'm talking about, right? You're not that. I know it's the post-lunch lull, but cerebrally, if it's hyperkalemia, kalemias do the what? Same as the prefix. The prefix is hyper, so everything in the brain is going to go up because it does the same in hyper. So if you talk about the brain, what symptoms are hyper signs in the brain? Give me some hyper signs in the brain. Agitation, restlessness, irritability, aggression, obnoxiousness, decreased inhibitions, loud, boisterous, right? Those all go with hyperkalemia. All right, well, let's talk about the lungs. What are you going to see there? Tachypnea. What are you going to see in the heart? Low heart rate, because there's the exception, but the T waves will be peak, tall. The STs will be elevated. See, the only thing that goes up is the heart rate. Everything else about the heart goes with the prefix. Okay, what will you see in the bowel? Diarrhea, borborygmi. What will you see in the muscle? Spasticity, increased tone. What will you see in the reflexes? +3, +4. And all those signs, what do they have in common? They're all up. Why are they all up? Because you have hyperkalemia. And in kalemias, they do the same as whatever the prefix says they are, except for the heart rate and the urine output, which goes opposite. So what would you list for hypokalemia? Lethargy. Tachycardia, because it can go opposite there. Tachycardia and polyuria. What? Bradypnea. Bowels are going to be what? Slow down. So what might you have? Ileus, constipation, all of that. What are you going to see in your muscles? Flaccidity. What are you going to see in reflexes? +1. Do I want you to memorize these lists that we're generating? No. Because you can get those lists from the saying that says what? Kalemias do the same as the prefix except for heart rate and urine output. Are you seeing where I'm going with this? Okay. Your patient has hyperkalemia. Select all that apply. Adynamic ileus. Obtunded. +1 reflex. Clonus, which is, okay? U wave. Depressed ST. Let's see what I want to do here. Polyuria. Bradycardia. Okay, I want you to look at it and then talk to your buddy, partner, see if you can select. But use the sentence. Kalemias do the same as the prefix except for heart rate and urine output. And draw your arrow. So you're going to have to draw an arrow, and you're also going to have to draw the exceptions, which is the heart rate and the urine output. Oh, that should say hyper. It says hype. Hyper. There's an R there. Sorry, guys. Hyper.
What about the U wave? It says just U wave,
A U wave. A U wave is a wave that goes like this.
up and down.
It goes what? Down.
What is that?
Fluid polyuria is up, hyper, urine goes down.
Okay, so okay, high, so everything's going to
Make sure you get all your arrows right. You need to draw a general arrow, an arrow for the heart rate, and an arrow for the urine output. Make sure you get them right.
Okay, hyper, so everything's going to go up except for heart rate and urine. So we need to go to urine, which is going to make them go low. So it wouldn't be that. Hyper, so wait a minute. Except for everything's going to go. I know it would be bradycardia because it's going to be opposite.
Bradycardia is the
It wouldn't go high. It would do opposite. It would go low. Okay, so that.
Okay, how many did you select?
Hyper.
Okay, I selected 2. Let me see
I
if
got
I'm
2.
wrong. Okay? Because I'm going to write my arrows out first. I see hyper, and I know Kalimi's do the what? Same, so it's going to make everything go up, but heart rate's going to go down, and urine output's going to go down. Okay, A, dynamic, without movement. Ileus, that's down. That does not fit. Obtunded, that is down. That is not fit. +1 reflex, that is down. That does not fit. Clonus, that is irritability. There we go, that fits. U wave, it goes down. That doesn't fit. Depressed ST, it's going down. That doesn't fit. Polyuria, oh no, it should be oliguria. That doesn't fit. Heart rate down. Bradycardia, yeah, that fits. Now, those of you that did 3, which one did you add that you shouldn't have added?
Polyuria.
You forgot to write the... See, if you forget to write your arrows, you're dead in the water. You got to write your arrows. Then go looking. Don't look first and then go back and write arrows. You know what I'm saying? Know what you're looking for first.
Know the meaning of the words too.
Yeah, meaning of the words is helpful, yes. The U wave, a U wave is something that starts on the baseline and goes down from the baseline. So it's a sign of cardiac depression. And the idea, though, Leonid, is if you don't know what something is on a select all that apply, don't pick it. Because everybody tends to what? Over-select by 1. Isn't that what you guys did? You over-selected by 1. I mean, it's like predictable. Yes?
What does obtunded mean again?
Obtunded is just a little more comatose than lethargy. So you got lethargic, and then as you go even more deep into a coma, you get obtunded. A lethargic person, ask me a question, and I'll be lethargic. Just ask me a question.
Where do you live?
No, say that.
What's your name?
Mark.
Where do you live?
Okay. See what I'm saying? Or she'd say Mark what? Do you see what I'm saying? Okay. Now that's lethargic. Okay. This is obtunded. Okay.
What's your name?
You know, what would you do? What would you do? You're a nurse. Do what you would do.
What's your name? What's your name?
Do you see what I'm saying? Now what's comatose? So obtunded, they pretty much you can rouse them and then they go off to la la land, and then you rouse them and they go. Lethargics will respond, but It's going to take a while to get it out. Obtundids will never respond, but they're rousable.
Okay.
Yes?
The stupor follow obtunded?
Stupor and obtunded are often considered to be the same idea. Stupor is more a generic word. Obtunded is more the medical term. Usually, go on. I won't go there. It doesn't need to happen. Okay, calciums. Calcemias do the opposite. Calcemias do the opposite of the prefix. Which means if your calcium goes high, everything goes low. And if your calcium goes low, everything goes high. So hypercalcemia, what would you have? Bradycardia, bradypnea, flaccid muscles, hypoactive reflexes, lethargy, constipation, right? Everything goes down when calcium goes up. However, when calcium goes down, hypocalcemia, everything goes up. So what do you get with hypocalcemia? Agitation, irritability, clonus, +4 reflexes, spasm, irritability, seizure, tachycardia, all that kind of stuff. And you get two other things, Chvostek's sign and Trousseau's sign, which Hesse loves. Trousseau's and Chvostek's. Chvostek's starts with what two letters? CH. And what do you do to elicit it? You tap the cheek. So just think Chvostek's cheek. Chvostek cheek. So when you touch their cheek with Chvostek's, they go into a spasm of the face. Their face spasms. Which shouldn't happen. If I touch you on the cheek, you should go. And you shouldn't go. That would be Chvostek's. What is it a sign of? It's a sign of neuromuscular irritability associated with a low calcium. It is a sign of neuromuscular irritability associated with a low calcium. Why does that sentence make sense? Irritability, low calcium. Why does that make sense? Because calciums do the opposite, so irritability would have to be low calcium. The other sign is Trousseau's. Trousseau's is when you put a blood pressure cuff on their arm, you pump it up, and they go into a spasm of the hand. So it's a hand spasm when you put a blood pressure cuff on. So Chvostek's, you do what? Cheek. Trousseau's, you do blood pressure cuff and look for that. Stupid way I remember this. Really dumb, but it works for me. Trousseau sounds like a French name. So when I see Trousseau on a test, I think of an effeminate Frenchman. And he says, I'm Trousseau. So, so that Trousseau's. So I know it's weird, but, it may stick.
I was thinking Jacques Cousteau.
Jacques Cousteau. Okay. Boards live Hesse test. Those of you that are going to take Hesse, they will test Chvostek's and Trousseau's till the cows come home on that. They'll love it. All right. Hey, by the way, what if I change this to hypercalcemia? Would it change the answer? Yeah. Because now you're looking for what? Calciums do the opposite. This says hyper, so it's going to make everything go down. So you're going to see this and this and this and not that and that and that and that and not this. Oh, you will see that. Yeah, you will see. You will see that. Yes. I'm sorry. I got a little pen heavy there. You see? So it's really. Yeah, you won't see polyuria. It's really good when you guys are better than me at this. That's what we need to be, because I'm not taking the test. You are. Okay. But do you see what I'm saying? It really is more manageable. Now, if they ask you which sets of these, like for the hyperkalemia, if they ask you which one of those was most likely, you'd have narrowed it down to 2. Which 2? Clonus and bradycardia. But because it was potassium, you'd give the edge to the heart. If they're talking calcium, you'd have all these things, but you'd give the edge to the muscles and the nerves. Do you see what I'm saying? So there is that little, but make sure it's the right thing first before you do it. You know what I mean? But if you're between a couple of signs for potassium that are correct, and they're asking you to pick between them, for potassium, pick the heart sign, but make sure it's going the right way for the prefix, correct? And when you're talking about the calcium, pick the skeletal muscle and nerve, but make sure it's gone the correct way. All right, let's talk about magnesium. Number 3, magnesemias do the opposite of the prefix. Now, some review books out there say that hypomagnesemia is not associated with hypertension. Because it does the what? Magnesiums do the? So a hypomag would result in high blood pressure. Some books say, no, that's not true. Check it out. Go investigate, and you'll find that low magnesium is associated with hypertension. Okay, so some of these books get a little sloppy in their answers. Who had that exam cram book yesterday?
Don't they say that magnesium often, like if it's high sodium, high magnesium? So then that's kind of...
Yeah, a lot of times they'll say that when you retain sodium, magnesium sometimes gets retained. So they say that high magnesium is associated with hypertension, but no, it's really a function of the high sodium, not the magnesium.
Yeah.
If you just talk about magnesium itself, the low magnesium has the high pressure.
But then it is kind of related.
But it is kind of related, but it is not a symptom of or a sign of. So what will boards do as far as blood pressure and magnesium go? They won't even go there, because that doesn't tell them anything significant about you. It just tells you on what side of the debate are you on, that kind of thing. Just a little thing about, people have asked me about using multiple choice books to study for boards, those multiple choice books. What have I told you about them already? 1 out of 5 answers is bogus in those books. 20% of the question in those books are wrong. They are wrong. And when you do them, you think they are all, what, 100% right. And and you start to doubt yourself when you're the one that knows what's right and the book is wrong. So you have to be real careful. When you do those books, do I want you to do them? Yeah. But how do I want you to do them? If you answer an answer and you know it's right, you go to the rationale, they say you're wrong, what should you say? What do I want you to say? It's bogus. I am not having my confidence destroyed. I do know what I'm talking about. The book is wrong. I mean, there was a classic one on the exam cram the other day that you showed me at SASC. Which patient needs a private room? And there was a patient with Cushing's syndrome in there. Well, Cushing's people are immunosuppressed. They should be in a private room. The other patient was hyperthyroid. And they said a hyperthyroid should be in the room because they don't sleep well because they're hyperthyroid. And if they had a roommate, they wouldn't be able to sleep real well. Well, my opinion is between somebody that isn't sleeping and somebody that's immunosuppressed, there's no... Any nurse you ask would say, do you see what I'm saying? So you got to watch those books. And then even in that book, which is the book I like the best, I think it has the best questions of any book. I have real problems with it. In one of the chapters it said that hypokalemia is not seen with Cushing's. Absolutely it is. With Cushing's you've got a lot of what? Aldosterone, which makes you retain sodium and water. Well, to retain sodium in the loop of Henle, what do you have to kick out? Potassium. So you do get hypokalemic. And then in chapter 8 or 9, they ask about it again, and they say that you do see hypokalemia with Cushing's. So in chapter 3, they say you don't, and in chapter 8, they say you do. That's the state of the art of those books. Do you see what I'm saying? So when you go do these books, and you know your stuff, and you're ready to go, and it's telling you, no, you're wrong, you're wrong, you're wrong, you're probably what? You're right, you're right, you're right. Well, they just, yeah, I mean, they're not, they're putting out a product to make money.
Right.
And the faster they can get it done, with the fewer people looking at it, the more money they make. Okay? We took, 3 faculty at Cedarville took the HESI test, and there's 160 questions. We disagreed with 30. And your faculty would too, if they took the test. They would disagree. And with ATI, they would disagree with even more. But they've never taken the test, so they don't even know what's on it. Do you see what I'm saying? They don't even know what's on it, and they're asking you to take it, and they're making decisions based on something they've never seen. And I'm telling you, they will. You tell them. He said, you take that test. You take that test, and you see if you disagree with, and they'll disagree with, I guarantee they'll disagree with at least 10 to 15%, if not 20 to 30%. They really, really will. But that's no excuse to get a 650 on the HESI. You understand what I'm saying? If you disagreed, if you missed all the questions that were bogus on HESI, you know what you'd end up with? If you missed all the ones that were bogus and you got like 80% to 90% of the ones that really were valid, do you know what score you'd end up with a HESI? An 1100 something. Do you see? So that's not going to flunk you on. You know what I'm saying? I'm telling you 2 things. I'm telling you they have a lot of bad questions on there, but those bad questions aren't going to be what? Don't say, oh, they're going to get. No. You have to not know some things too. All righty? Question?
Oh, I was just going to say, our school, they weight so much on the ATI that if you get below a level, you get 15 points off your whole points system, so that could totally...
I would just, when after you graduate, that's the best time to go back and just ask them and say, have you guys taken the ATI? No, have you taken it? No, honestly, have you taken it? Do you know what's on it? Have you seen those questions? Do you know what the question? Have you done a quality inspection of the product that you're putting? Do you know the product that you're putting so much weight on? See, I wrote my test. I wrote my final in my course, so I know. So when I say you fail it, I say you fail it because I wrote that test and I know that test. But a test I don't know, how do I know what it's like? These products are not that fantastic. The boards is fantastic. These products are not. You see what I'm saying? No, but then having said that, I'm saying that there's no reason not to get a reasonable score on these, even with those horrible questions. Okay? All right. But what I don't want you to do is this. I don't want you to learn a lot, know a lot, go take these questions and take 100 of them and have your confidence totally destroyed because they don't agree with what you said. Do you see what I'm saying? And you tend to only focus on the ones that you didn't agree with, not the 100 you did get right. You tend to focus on the 4 or 5 that you missed. Isn't that the way we are? Mm-hmm. So don't let those destroy. How many find that doing those batteries of questions are the fastest and quickest way to destroy your confidence? Yeah, and that's not what they should. That you shouldn't even be doing them if that's what it's doing. Do you understand what I'm saying? Okay. All right. So magnesiums do the what? Opposite. Now, can you have a tie? Could it be possible that a certain symptom could be caused by a magnesium imbalance or a calcium imbalance or a potassium imbalance? Could that happen?
Yeah.
Sure. So how do you break those ties? Well, here's the tiebreaker. In a tie, don't pick magnesium. Why? It's not a major player. So it's probably not the magnesium that's causing the problem. Number 2, if it is skeletal muscle or nerve, blame it on calcium. For everything else, blame it on potassium. So let me show you what I'm talking about here. I'm talking about this kind of question. Your patient has diarrhea. What caused it? Hyperkalemia, hypokalemia, hypocalcemia, hypomagnesemia. All right, now, you know it's an electrolyte question, right? So you know you're going to be playing games with arrows, correct? So is this symptom up or down? So you got to find something that causes stuff to go up, the bowel to go up, right? Okay, potassiums do the what? Same. So hyper makes everything go. So could that cause that? So that's a possibility, is it not? Kalemias do the same. Hypo makes everything go down. Could that cause that? No, that's out. Calciums do the opposite. So hypo makes everything go up. So could that cause that? Yes. Remember, they're in the same direction that could cause it. Magnesiums do the opposite. So hypo makes everything go up. So could that cause that? Yes. So we have a what? Tie. So what don't we pick in a tie? So we rule out D. Is this skeletal muscle or nerve? No. So what do we rule out? Calcium. So we blame it on the high potassium. Are you seeing how that works? Let me show you another one. What if it said tetany? Is that up or down? Up. So let's do the same. Kalemias do the same. So hyper makes everything go up. So could that cause that? Yes. Same, down. No, that would be out. Calciums do the opposite. So low calcium makes everything go up. So could that cause that? Yes. Magnesium does the opposite. So low makes everything go high. So could that cause that? Yes. So we have the same three-way tie we had with diarrhea, correct? Now, what do we rule out first? The magnesium again. Is this skeletal muscle? Yes. This is skeletal muscle and nerve. So now we blame it on the what? The calcium, and we don't go any further. Now let me show you what mistake people make with electrolytes. Your patient has tetany. What caused it? A high potassium. B, a high calcium. C, a low magnesium. Do you know what? 90% of students taking this question without understanding what I just taught you would pick for this one? The high calcium. Because they've got burned in their brain calcium muscles, calcium muscles. If it's muscle, it's calcium, right? So they're going to pick high calcium, and they're going to be dead wrong. Why? It's going the wrong way. You've got to use your sentences first. Potassiums do the same, so this could cause that. Calciums do the opposite, so that's going to make everything go down. That would be ruled out. See how the answer that everybody would pick should be the first one ruled out, because they're not using what? Their sentences. And they just think muscle, calcium, potassium, heart. And they don't even look to see if it's going the correct direction. How many think you might have done that? If it's potassium, it's heart. If it's calcium, it's muscle. And then you don't even look at the prefix. Okay, so look at the prefix first, then use potassium, heart, calcium, muscle for tie breaking. Yes?
So if it was low calcium, or I'm sorry, low calcium, you pick that then over potassium.
This could cause that. This could cause that.
That's specific.
And this could cause that. Okay, now our tiebreaker is in a tie. Don't pick magnesium. If the symptom involves skeletal muscle, which it does, pick the calcium. And you don't have to go any further. But you got to go through for the first time to make sure that your prefix agrees with the symptom. You have to make sure that that imbalance would actually cause it. Then you go break your tie. Second, what most people do by mistake is they use the tiebreaker first. Do you see what I'm saying? They rule out magnesium. For skeletal muscle, they pick calciums. And for everything else, they pick potassium. And they don't even look to see if it's even feasible. That's the problem that people have. Question? Okay. All right, let's turn the page and talk about sodiums. Do you see the one with the E? I want you to write dehydration, using it like an acrostic, like a crossword puzzle. Put the D over top the E, and then write hydration down. The one with the E, hypernatremia, is associated with dehydration. You see over in the other column, the one with the O? Write the word overload down from that. Overload. Aren't dehydration and overload opposites? So when you get a hypernatremia, what should you see? The letter what? E, which tells you it is the same as dehydration. And when you see hyponatremia, you should see the O and say that's the same as fluid overload. So here's how you would use this. The one with the E is dehydration. The one with the O is overload. And you're using sodium here. So if they said this, a student nurse runs to you, the LPN, and says, oh my goodness, I just ran an IV, a whole liter of IV fluid into the patient in 10 minutes. I forgot to close the clamp. Okay? Ran a whole liter in 10 minutes. I forgot to close the clamp. What electrolyte imbalance would you expect to see? Why did you say hyponatremia? Because they would have had fluid overload, and you'd have been absolutely 100% correct. Which patient is put on a fluid restriction and Lasix? Hyponatremic. Which one is given lots of fluids? Hypernatremic, because that's dehydration. Who has hot, flushed, dry skin? That describes what? Hypernatremia, so that's the one with the E, so that's dehydration. So here's my point. If you had a 20-question test over dehydration and fluid overload versus a 20-question test on hypernatremia and hyponatremia, which one would you rather take? The dehydration overload. But what's the reality? It's the exact same test. Because anytime you see dehydration, you say what? Hypernatremia. Whenever you see overload, you say hyponatremia, and vice versa. So in addition to a high potassium, what other electrolyte imbalance is possible in DKA? In DKA, what other electrolyte imbalance is possible? Hypernatremia. Why? Because wherever you see the word dehydration, you can throw in the word hypernatremia. Anywhere you see hypernatremia, you throw in the word dehydration. So what nursing diagnosis would be major for hyponatremia? Hyponatremia, what major nursing diagnosis? Fluid volume excess. Exactly. Or SIADH would have hyponatremia. DI would have hypernatremia. And HHNK would have hyper, because HHNK is the same as dehydration, which is the same as hypernatremia. Is that sort of easier for you? Okay. So what do you have to know your electrolytes? Here's what you have to know. Kalemias do the same as the prefix except for heart rate and urine output. Calciums and magnesiums do the opposite. The one with the E is dehydration. The one with the O is overload. That's it. Now, if you use those, kalemias do the same as the prefix except for heart rate and urine output. Calcium and magnesium do opposite. The one with the E is dehydration. The one with the O is O. Could you give me 15 signs and symptoms of hyperkalemia, hypokalemia, hypercalcemia, hypocalcemia, hypermagnesemia, hypomagnesemia, hypernatremia, and hyponatremia with 80% accuracy? Who could do it? And are you memorizing stuff? No, because those lists won't stay. Okay? So, but you need to memorize what? Kalimas do the same as the, except for
Heart and your
calcium and magnesium do the one with the E is, the one with the O is. Okay, so learn that. Otherwise, learn your lists. Have at it. Be my guest. Okay, the earliest sign of any electrolyte disorder is numbness and tingling. The earliest sign. So if they said to you, what would be the first thing you would see? What would you say? Numbness and tingling. Now, vocabulary, this word means numbness and tingling. Paresthesia. So boards will say paresthesia instead of numbness and tingling. One thing they love to say is circumoral paresthesia. What's that mean? Numb and tingling lips. So that's a very, very early sign of these electrolyte disorders. The universal sign of electrolyte imbalance is muscle weakness. All electrolyte imbalances cause muscle weakness. They all do. Does anybody know the fancy word for muscle weakness? Paresis. You need to know those two words, paresthesia and paresis. Paresthesia is numbness and tingling. Paresis is muscle weakness. All right, that's it on signs and symptoms. Let's talk about treatment. And the only treatment they're really going to test is potassium. All righty? First rule, never push potassium IV. Everybody knows that? Good. Never push potassium IV. Number 2, not more than 40 of K per liter of IV fluid. Now LPNs, you probably don't have to worry about this, but RNs, on your test, if the doctor writes an order for 60 of K in the liter, you're supposed to call and clarify. 40 of K, you don't call, you don't clarify, you just follow the order. But if it's over 40, you question and clarify. That's pretty standard. Okay, 3 and 4. Numbers 3 and 4. These are ways to lower a potassium. Why is a high potassium such a bad thing? It stops your heart. Cardiac arrest. So what is the most dangerous electrolyte imbalance of them all? High potassium. Of all the electrolyte disorders, the worst one is a high potassium. It beats all of them because it can stop a heart. So we need to know how to lower that potassium. So number 3 is the fastest way to lower the potassium, and that is give D5W with regular insulin. Give D5W with regular insulin. What's that going to do? It's going to drive the potassium into the cell, out of the blood. And it's the potassium in the blood that will kill you, not the potassium in the cells. So does D5W and regular insulin get rid of the excess potassium? Yes or no? No. What does it do with it? It hides it. Hides it where? In the cell. Does it really solve the problem? No. Then why do we do it? To save their life. Sometimes it's so high and that heart is being so negatively affected that we got to get that potassium down fast. We don't have time to solve the underlying problem. We don't have time to get the kidney kicking it out. We just have to get it out of the blood as fast as we can do it. It's sort of like your floor is dirty as all get out. Company's coming in the driveway. So what do you do to the dirt? Sweep it under the rug and throw the rug back down because you don't have time to what? really clean the floor. That's the way this is. With this, we're just sort of sweeping the potassium under the rug. Now, what's going to happen over the next few hours after this works? It lowers the K. Fantastic. Now, what's going to happen over the next 8 hours? The potassium is going to leak right back into where? The blood, where it could kill you again. So this is, what's the upside of this one? Fast and quick. What's the downside? Temporary. Which is why we use the other one, K-exalate. Now, K-exalate goes into your gut. It either is put through your mouth or through your rectum, in enema or a ingestion. And it's full of sodium. It's chock full of sodium. Now, as it sits in your gut, what do you think it liberates into the blood? Sodium. But to maintain electronegative equilibrium, what has to be kicked out of the blood into the gut? Potassium. And where does it? It's picked up by the K-exalate. So the K-exalate goes in full of sodium, but it trades sodiums for potassium. So when you defecate the K-exalate out, what's it full of? Potassium. Now, how did your blood start out? High in what? Potassium. It ends up high in sodium. So you have what imbalance? Hypernatremia. That's the one with the E. So that is just simply dehydration. So we give them fluids and we correct that problem. So what we're doing is we're trading a non-life-threatening electrolyte imbalance for a life-threatening one. You know what I mean? We're getting rid of a life-threatening imbalance and giving them a non-life-threatening imbalance. But they still have an imbalance when we're done. Now, what's the good side about K-exalate? What's the good side? What's that?
Does it last longer?
It lasts longer, yes, but there's a reason why. It lasts longer. Why? It gets rid of the excess potassium out of your body, never to reoccur. Okay, well, what's the downside of K-exalate? Well, yeah, you get hypernatremic, but that's not the worst downside.
Takes a long time.
It takes a long time. It takes hours, and you may not live that long. So what's the advantage of D5W regular insulin? What's the downside? Temporary. What's the upside for K-exalate? Permanent. What's the downside? Takes a while. So what do you think we do simultaneously? We give them both. What lowers the potassium right away? D5 regular insulin. As it starts to come back out of the cell, who picks it up? K-exalate, and out it goes. So, let me ask you this. What electrolyte does K-exalate work with? For calcium, magnesium, or potassium? Potassium. What's the symbol for potassium? Now, does K-exalate make potassium enter the cell or exit the body? Does it do it fast or slow? Early or late? Say that real fast. Okay, so the minute you see K-exalate, what should you think? K exits late. Potassium leaves the body, but it's going to take a while. Well then, so if K exits late in K-exalate, then what happens with D5W and regular insulin? K what? Enters early. Do you see what I'm saying? So if you know that K exits late in K-exalate, then you know what D5W and regular insulin does, which is the opposite of that. It doesn't exit, it enters, and it doesn't do it late, it does it early or fast. Okay? Do the practice question at the bottom of the page using the rules that I taught you. Do not use your normal thinking. Use the rules that I taught you. I want you to think through it. Remember, if a answer is part wrong, it's All wrong. And when you get an electrolyte question, what is it all about? Drawing what? Arrows. Yeah.
I don't know what it is, but because I took a case talking to the ball. But you know that there's something too you can also give. It's only temporary though. It protects the heart. I feel like it's calcium.
Yeah, you can give, calcium gluconate can work, yeah.
Is that more like?
No, that's more of an emergency
Okay.
situation. They're going to ask about treatment that you're going to do on a unit in a non-code, non-emergency, yeah. Okay, what answer did you guys come up with? How many said A, B, C, D? Okay, how hard was this question? Scale of 0 to 10. 0 being easy, 10 being unbelievably difficult. What would you give it? 1. 1, 2, 3. An hour ago, what would you have given it? So what did you see? What did you notice? What word did you notice? Hypercalcemia. Calciums do the? So it's going to make everything go. A negative inno, negative chrono, negative dromotropic effect right on the heart and everything else. Okay, so what's wrong with A? Why did A not get your answer? Tacky, killed it. Why did B not get your answer? Elevated. Why did C not get your answer? Tall. So what was good about D? Decreased, inverted, blocked. Right? Okay, good job. And you don't have to, see, the nice thing about it is you don't have to, it's actually testing your knowledge of the principles of what it does, but you don't have to memorize all fancy stuff, okay? All right, take a break, come back at 20, at half past. $60 mil per drop. No, 60 drops per mil. And micro is the same. Okay, mini and micro. They're synonymous. No. Which leg of yours is weak one? You hold it on the side. And advance it with the wheel. Yes, the one that goes by itself. This is the weak one. That goes together. Yeah. And then I go like this, and now I'm on my bad one by itself, which is cool. And the weak one gets that. And see how wide the base of support is? Yeah. That's better than having it over here when you're narrow. Okay. Let me ask you. Your client had a right CBA. In which hand will you get that CBA and see right. Really? Y'all have to pay attention next week.
You are in the clinic, not in term pay. It's just always around time.
Okay, let's start. Endocrine overview. Endocrine glands. This lecture is going to be real helpful for HESI stuff because they love to test adrenals and thyroids. The endocrine overview is only going to be about thyroids and adrenals. You do not have to know the thymus, the pineal, the parathyroids. You don't have to know all those. Just know your thyroid gland, know your adrenal gland, and you're good to go. Now, if you don't know your thyroid, you're in trouble. If you don't know your adrenal, you're in trouble. So focus on what you need to know. So let's focus on those two glands. The first one is hyperthyroidism that I will talk about. Whenever Mark Klimek sees the word thyroidism, he turns it into metabolism because that's what the thyroid does. The thyroid regulates metabolism. So when you see hyperthyroidism, what do I want you to turn it into? Hypermetabolism. If that is true, do you see that now you do not have to memorize the signs and symptoms? They're just logical. What would be the logical set of signs and symptoms you would see if you had a high metabolic rate? Weight loss. So they're skinny and weight loss. What else? What would their pulse rate be? Blood pressure. Their personality. Irritable, hyper, obnoxious, excitable. Life of the party for about 5 minutes till everybody gets sick of them. Heat. What? Intolerance and cold tolerance. So they can tolerate the cold because they're like a little furnace. They cannot tolerate the heat because they're already burning up. Exophthalmos. What's exophthalmos? Bulging eyes.
What was the word for that?
Exophthalmos.
Okay, I got it now.
Exophthalmos. So they're skinny, they're hyper, they're tacky, they're hypermetabolic. The person I remember, this dates me too, you guys probably do not know him, was a guy named Don Knotts that was,
He's hilarious.
what was he? He was
Barney Fife.
Barney Fife on Mayberry, you know, the skinny little guy, Sheriff Andy, and he's always hyper, bug eyes, skinny, classic hyperthyroid guy. The name of this disease is Graves, Graves, Graves disease. Now they will not tell you, they will not say Graves disease, hyperthyroid. They'll give you one name, and you're supposed to know Graves is hyperthyroid. The way I remember that is a saying my grandma used to say, which is, you're going to run yourself into the grave. What two words does that link? Run with grave. Well, if you're run all the time, what are you? Hyperthyroid. So running yourself into the grave helps me remember it's hyperthyroid. Number 3, the problem here is hyperthyroidism. So you have 3 treatment options. You have 3 ways to treat hyperthyroidism. Number 1, radioactive iodine. Radioactive iodine. Now there's 2 things you need to know about radioactive iodine. Number 1, the patient should be by themselves for 24 hours. They should be in a room by themselves for 24 hours. And after that, they have to be real careful with their urine. They should flush 3 times. If they spill their urine on the ground, they need to call the hazmat team, because somebody has to come with a Geiger counter to make sure it's all cleaned up. So if you have a patient on radioactive iodine for hyperthyroidism and they spill urine on the floor in the hospital, you can't call housekeeping. You got to call your hospital hazmat team, and they come with all their paraphernalia. It looks really, really silly for them to go worrying about the urine. But that's where the radioactivity is excreted, is through the urine. So this is the one place where they have glow-in-the-dark urine. Not really, but you have to treat it like it's bad. So the only risk to you, the nurse, for a patient who's had radioactive iodine is what? Their urine. and give them a private room in the first 24 hours. Okay, the next treatment we have is PTU. PTU. A drug. Yes?
Would you get family visitation on that? Is that an issue? I've seen several ATI questions.
With radioactive iodine, no family visitation in the first 24 hours. And if they go home, they are supposed to stay in the family room and nobody else, or they stay in their bedroom, nobody else goes in for 24 hours. So there's a restriction of visitors, home restriction for 24. After 24, they can have all the visitors in the world as long as they don't pee on them. Okay, the second problem is PTU, propylthiouracil. Propylthiouracil. Now, I don't want you to memorize that PTU is propylthiouracil. What's it used for? Hyperthyroid. So what must it do to your thyroid? If it treats hyper, what must it do? Bring it down. So I want you to remember that PTU stands for puts thyroid under. Whenever you see PTU, what should pop in your head? Puts thyroid under, which tells you it treats hyperthyroid. Its primary use is for cancer. It's a cancer drug. But one of its special uses is for hyperthyroids because it will also put the thyroid under. So what do you think the number one nursing thing is with this drug, if it's a cancer drug? Immunosuppression. So what blood values do you have to watch when they're on PTU? Their white blood cell counts. So it puts the thyroid under, and it also knocks down your white count. The most common way, however, that we treat hyperthyroid is surgical removal. We do a thyroidectomy. Thyroidectomy. We remove part of the thyroid or all of the thyroid. Now, if you want to get your thyroidectomy questions correct, you must pay attention to whether they're talking about a total thyroidectomy or a subtotal thyroidectomy. Because that's going to make a huge difference in your answer. If you just treat all thyroidectomies the same, you will miss loads of questions. So what's the most important thing in a thyroidectomy question? Total or sub. Now, I taught this one time, and a student called me the day after and said, what you taught didn't help on thyroidectomies. And I thought, okay. And I said, well, what didn't help? And she said, well, there was a different kind of thyroid surgery on there that you didn't cover. I thought, boy, that's interesting. Total, subtotal. That pretty much covers it for me. I can't think of, it's either total or it's subtotal. I mean, what third possibility could there be? And I said, well, what was it? And she said, it was a partial thyroidectomy. Subtotal is a partial, total is a complete. So a complete thyroidectomy is a total, a partial is a subtotal. Now she passed, so you don't have to be, a real shining light. You just have to do some shining. She certainly was not a shining light. Why did she make such a dumb mistake? She wasn't managing her anxiety. And she was looking for total and subtotal, and it wasn't there. She panicked, and she didn't say, now wait a minute, which of these is closest to what I do know, right? Because it may not say it exactly the way you want it. Remember the guy with the cracker and the dry carbohydrate? They'll say things differently than you learned them, but it means the same thing. If you see something on the test that means the same as something you learned, but it's saying it differently, guess what? It is what you learned. Don't say, well, That sounds like the same thing, but I didn't learn it that way, so it's probably not that. Oh, that is the worst thing to do. You should do the opposite. You should say, that sounds an awful lot like what I learned, which was this. It's not the same phrasing, but it sounds like that, so it must be that. Do you see the difference? Always assume that if they tell you something synonymous, that it means the same as what you know. Don't assume it's something different. Always assume it's what you know. Okay, so for totals need lifelong hormone replacement. Why? Because if I take your whole thyroid out, you don't have any. So you got to have lifelong hormone replacement. Also, letter B, you are at risk for hypocalcemia. Why low calcium? Why, after a total thyroidectomy, do you have a low calcium?
Thyroid.
Because it's almost impossible to spare the parathyroids when you take the whole thyroid out. So you end up with low parathormone, low calcium. So they're at risk for low calcium. What are the signs and symptoms of hypocalcemia? We talked about that last hour. Calciums do the opposite. So hypocalcemia is going to make everything go up. So you're going to have tetany, spasm, irritability, clonus, seizure, tachycardia, hypertension, irritability, jitteriness, tremor. Right? What's the first sign that's going to happen? Paresthesia. Excellent. See, once you start learning enough, things start cycling around and it's all no news, right? It's old news. What two signs will you have? Chavostex and Trousseau's. Because your calcium is low. Okay, subtotal thyroidectomies, on the other hand, do not need lifelong replacement. Why? Because you got some left and it's supposed to kick in. Might you be on hormone replacement for a little while? Till that other one kicks in, then it's supposed to be off. Do you think you get the hypocalcemia much with this? No, because if you only take out part of it, you can spare your parathyroids and your calcium's fine. However, what these people are at risk for is something that totals never get, and that is thyroid storm or thyroid crisis. Same thing. It also has another name, thyrotoxicosis, which sounds like a toxic thyroid, so that sounds like hyperthyroidism to me. Thyroid storm. Now, what are the symptoms of thyroid storm? 4 really bad things. Number 1, super high temperatures of 105 and above. Number 2, extremely high blood pressures. Stroke category. So you're probably talking 210 over 180. Now, I'm just giving you that as a ballpark. That's no set in stone number. Severe tachycardia, probably in the 180s. Could be as high as 200. And there again, that's just a ballpark. There's nothing magical about that number. And lastly, they are psychotically delirious. They have psychotic delirium, which we talked about before. These people are in a medical emergency. This thyroid storm is a very, very bad thing because it can cause brain damage, and brain damage is permanent. You literally fry your brain to death with hypoxia and or hypoxia. So you must treat this immediately, and what you treat it with is get the temperature down and get the oxygen up. Get the temperature down, get the oxygen up. Well, how do you get the temperature down? What's the first way you would do it? ice packs. What's the best way?
Cooling blanket.
Cooling blanket. Because if you would pack him in ice without the cooling blanket, use the cooling blanket without the ice, which way would be better? Ice without the cooling blanket without the ice. What's better? Cooling blanket without the ice. So the best is the cooling blanket. But what would you do first? First I'd put him in ice, then I'd order the cooling blanket and have it there. So you see there's another first best difference. And what would you give how do you get the oxygen up? Oxygen per mask at 10 liters. Just as an interest note, what's the problem with that order? What do you think you experience when you try to implement that order? What's that?
Anxiety, agitation.
And these people are what? Psychotically delirious. So how likely is it you're going to keep an oxygen mask on this patient? Yeah, good luck. Good luck. So this is a medical emergency. You pack him in ice, order the blanket, throw a mask on him with high O2. And they will come out of it themselves without treatment, or they will die. And there's nothing you can do to make it go either way. It's just when that T3, T4 gets out of their system, they'll be okay. We don't want to medicate them, because if we medicate them, it could go the other way. So this is a self-limiting condition. All we're doing is sparing their brain until they come out of it. Now, I've seen this about 5 times in my career. The longest lasted 12 hours. The shortest lasted about less than 2 hours. But when you're treating these people, it's 2-on-1, meaning 2 staff for 1 patient. You need an aide and yourself, because you can't do it with just yourself. Yes?
What is Tylenol going to do?
Tylenol works in the hypothalamus, and at this point the hypothalamus is being severely threatened, because it's right near the pituitary, and the problem with the thyroid storm that caused it was the TSH from the pituitary. So that pituitary hypothalamic axis is part of the problem that's causing this situation. And Tylenol works in that hypothalamus, and it's not going to work. Tylenol just isn't going to do it. So you really have to, you know, pack them in ice. So you really don't treat a lot of it. It's kind of scary, because you're just sitting there, you know, doing what you can. All right. But I would say that good nursing care is going to save their life. Why? Because medicine isn't. Yes, question?
So you said, to clarify, first ice packs and then oxygen later.
Well, I mean, if you had to pick between the ice packs and the oxygen, I would do the oxygen first, the ice pack second, the cooling blanket third.
Okay.
But if I was between the ice packs and the cooling blanket, the ice packs go first. But I would always pick stay with my patient, because you don't leave your patient to go get the oxygen. You see what I'm saying? But it's a perfect world, so it's sitting right there. All right. Post-op risks. They love to ask you about thyroidectomies and post-op risks, because it depends on the type of surgery and it depends upon the time frame. So let's talk about this. You've got to know this. You have to know this. In the first 12 hours, it doesn't matter whether it's a total or a subtotal. It does not matter. The top priority is airway. Because where's your thyroid? So if you have edema in the area, what's it going to press on? The airway, the larynx, so trachea, so you've got to watch out. Second big problem is hemorrhage, because it's an endocrine gland which has a lot of blood vessels. So the top 2 in the first 12 hours for both types of thyroid surgery are airway and hemorrhage, which is pretty much standard, isn't it? Okay, now where the difference comes in is in the 12 to 48 hour window. If they give you a patient who's longer than 12 hours, but less than 48, Now you have to pay attention to what type of thyroidectomy was done. Letter A, the post-op risks 12 to 48 hours after a total. The big danger is tetany due to the low calcium. For a total, they get the tetany because of the low calcium. However, letter B, the post-op risks 12 to 48 hours for a subtotal is storm. What storm? Thyroid storm. So you see where they're different? But they're the same in the first 12 hours, but different in the next 36. So 12 to 48 hours after surgeries, what do totals get? What do subs get? Totals get tetany, subs get storm. Totals get tetany, and subs get storm. So TTSS, total tetany sub storm. Total tetany sub storm. TTSS. When? 12 to 48 hours after surgery. In the first 12, what is it? Airway and hemorrhage, airway and bleeding for everybody. All right. What's the big risk after 48 hours, by the way? Infection. Right? How long does it have to be before you're allowed to pick infection as a high priority? At least 42 hours. We'd prefer 72. Here's the deal. Never pick infection in the first 72 hours after anything. So if they had a trauma and it's been 36 hours, would you pick infection? No. They gave birth to a baby 8 hours ago. Would you pick infection? No. Never pick infection in the first 72 hours. You only pick infection after 72 hours, not in the first 72. Question?
Is tetany serious? They don't really know what
Tetany
it
is dangerous because your larynx can go into a tetanic laryngeal spasm, which would close the vocal cords in an irreversible spasm, which essentially cuts off your airway, and you die. Okay, hypothyroid. Hypothyroid is hypometabolism. So if hypothyroid's hypometabolism, what are the signs and symptoms of a low metabolic rate? If your metabolic rate is really low, what would you look like? Obese. What would your personality be? What's that? What? Flat, boring, dull, cold intolerance, heat tolerance. See, you cannot tolerate what you are. So if you're cold, you can't tolerate. You have cold intolerance. If you're hot, you have heat intolerance. Do you see what I'm saying? So hypos are always what? Cold. So they have cold intolerance. Hyperthyroids are always hot. So they have heat intolerance. So you cannot tolerate what you are. What would the pulse be and the blood pressure be? Low. If they were a test taker, what kind of test taker would they be? Slow, extremely slow test takers. They tend to get lower grades in school. Not because they're not smart, but because they can't process fast enough. It could even affect nursing practice in the sense that you don't think fast enough. Okay, the name of the disease is mixed edema. M-Y-X, M-Y-X, and then the word edema. That's the name of it. Okay, the treatment. Do you have too much hormone or not enough hormone? Not enough, so what's the logical treatment? Give them thyroid hormones. Synthroid, levothyroxine. Number 4, caution, do not sedate these people. Why do you not sedate them? Because they're already super slow. You sedate them, you'll actually put them in a coma. It's called a myxedemic coma. So what pre-op order would you question with this hypothyroid patient? Ambien at HS, the sleeping pill before surgery, the night before surgery, because they don't need that. Now, let me ask you this. You got a hypothyroid client. He's on thyroid pills every day. He's going to have a open heart surgery. He's scheduled for it in the morning. Doctor orders NPO past midnight. You got a problem with that? What's your problem? Call and question what?
That they're holding the med, the thyroid hormone.
Okay, because NPO means nothing, and nothing means nothing, including anything, which would be a pill. So nothing by mouth means they're not allowed to have any of their oral pills, which means you would not give the person their morning thyroid, which means they would be hypothyroid and very susceptible to any drug that would sedate them. Do you get any drugs during surgery that sedate you? It's called an anesthetic agent. Do you see what I'm saying? So if you would follow that order and not give the thyroid pill the morning of surgery, what could likely happen to your patient? Never make it off the table. They would die from the depressant effects of the anesthesia. So you as a nurse would never hold what pill before surgery without express orders to do so. Thyroid pills. Never hold your thyroid pills unless they tell you to do it. And even if they told me to do it, if I called the surgeon and he told me to hold the thyroid, what would I do? I'd call the anesthesiologist. And if he said hold it, what would I do? I'd call the head of the anesthesiologist, my supervisor, and say, hey, look, this is not cool. Now, my supervisor should what? Contact the supervisor of the anesthesiology and say, hey, look, what's going on here? You see, you aren't supposed to go up the ladder outside your department. You go up your department and they go across. Do you see what I'm saying? If I really felt it was unsafe, I would refuse to follow. I would just refuse to. I don't know. You understand? If I thought it meant a patient dying, how far would you go? You know what I'm saying? If it was your dad, what would you do to keep him from going to surgery? You'd lay down on the floor and not let him get the cart over your body. Do you know what I mean? So I'm just saying, would you do the same for your patient? Okay, enough said on that. Adrenal cortex. The second gland we're going to talk about, the adrenal cortex. Interestingly, adrenal cortex diseases start with either the letter A or the letter C, which are the initials of adrenal cortex. So could Graves be the adrenal cortex?
No.
Could myxedema be the adrenal cortex?
No.
Could pheochromocytoma be the adrenal cortex?
No.
Could Cushing's?
Yes.
Conn's? Addison's?
Yes.
Corticolinsufficiency?
Yes.
Adrenal insufficiency?
Yes.
Yes. So all of those diseases start with an A or a C. Now I didn't say that all diseases start with an A or a C, or adrenal cortex, because asthma, obviously, no. All right. Addison's disease, let's start with Addison's. It starts with an A. It's under secretion of the adrenal cortex. Under secretion. What are the signs and symptoms? Just two things you need to know. They are hyperpigmented. What does hyperpigmented mean? Very tanned. Very tanned. So they look what many people call healthy, but they are the farthest thing from it. Because the second thing you need to know about it is these people do not adapt to stress. They do not adapt to stress. Because their adrenal gland is under secreting. So if they undergo any stress at all, what could happen? What's the purpose of the stress response, I might ask? What's the purpose of the stress response? Not to increase the metabolism necessarily, although it will. That's what mediates it, but that's not the purpose of it.
Heart rate.
That's what it does, but that's not what the purpose. What? Okay, and but what's the big when you are under stress, there's a threat to your brain. And the purpose of the stress response is to perfuse the brain with blood, in other words, support the blood pressure, and give the brain glucose, which means raise the blood glucose. So the purpose of the stress response is to raise the glucose, raise the blood pressure. Does everybody understand that? Your stress response is supposed to raise your glucose and raise your blood pressure. That's what its purpose is. If these people do not have the adrenal cortex to carry out the stress response, when they undergo stress, what will happen? Okay, what's the purpose of the stress response? Raise the and raise the. And if you've got a disease in that organ and cannot do that, what will happen when you undergo stress? Your glucose will go down and your blood pressure will go down and you'll go into shock like that. And it doesn't take much to put them into shock. In fact, these people have been known to go to the dentist, have a tooth filled, and they go into full-blown shock because of that stress, which wouldn't bother most of us. If you ever work squad, these are the people that you happen on the scene of a little fender bender, and somebody's gone. No blood pressure, nothing. They're gone. And you think, well, they couldn't possibly have been hurt that bad. Well, you'll search them, and what will you find?
Really nice thing.
A really nice, a really tan guy wearing a bracelet. And what does the bracelet say? I have Addison's disease. These people, you look at them wrong and they go into shock. No, not really, but I mean, they are your time bombs waiting to go. This is a very scary disease. You're okay until something happens, and then wham, they decompensate like that. Yes?
I thought it was rare. Do you see it?
It's very rare. As far as endocrine disorders, it's one of the rarest. It's one of the rarest. It's like for every 600 Cushing's patients I would see, I see one Addison's. And that's probably being generous. I probably have only taken care of 2 or 3 Addison's patients in my entire life. Cushing's, all the time. Kennedy was supposed to have had this disease, JFK. Was rumored to have this disease. So that means when he got shot, what? There was no chance. There was no. I mean, even if it had been now, and if it hadn't gotten hit in the skull, if he had gotten like a shoulder injury now, he might not have made it. So it was. And think about this. What's really dangerous to people with Addison's disease? Stress. You're the president of the United States. It's not the best. He probably couldn't get elected right now because they would have made such a big deal of the you know what I mean? It would have disqualified him. But it was hidden. People didn't know about it. What's that?
He didn't seem very tan.
Well, he was a little bronzer though. Early years he wasn't. He was real pasty. But then he got tanned as he went on. And then he started taking steroids, so he got puffy.
Okay, yeah.
So the nice little puffy cheeks he had there near the end, that was steroids. That wasn't Jackie. Okay. Well, what's the treatment?
Steroids?
Yeah. Give him what he's low on, which is what? Steroids. Not pump you up steroids, but glucocorticoids. All drugs that end in what? What do all steroids end in? Zone. betamethasone, beclomethasone, dexamethasone, prednisone, mometasone, hydrocortisone, fludrocortisone. So drugs that end in -sone are steroids. So you give drugs, these drugs, to people in Addison's, right? So Addison's disease, is it under secretion or over secretion?
Under.
Do you have to take something away from them or add something to them?
Add.
And what do you add? A sone. In Addison's, you add a sone. And that tells you whether, doesn't Addisone tell you whether it's hyper or hypo? Sure, because if you're adding, it's what? Hypo, and it tells you what drugs to pick, anything ending in -sone. So just remember, Addison's, you add a sone. And that'll help you remember it. Cushing's syndrome. This is over-secretion of the adrenal cortex. Over-secretion. The way I remember this is, if you have a cushy bank account, do you have more or less money? More. If you have a cushy chair, does it have more or less stuffing? More. If you have a cushy tushy, do you have more or less? More, yeah, you got a whole lot more, right? A lot more. So, cushy just sounds like more to me, doesn't it? Cushing's, cushy, over. Addison's, you got to add because it's under. I never forget which one's under and which one's over. Okay, now, the signs and symptoms of Cushing's disease, you have to know this. They will test this, and knowing this list gets you what we call 2 for the money, which means when you memorize this list, you're actually getting 2 things. Number 1, you're getting the signs and symptoms of Cushing's, and number 2, you're getting all the side effects of steroid medications. So when you memorize this one list, you're getting 2 things: Cushing's signs and symptoms and side effects of steroids. Any drug ending in -sone. So that's good for a lot of reasons. Now, I am going to have you remember this by drawing a picture of a little man. And I'm serious, I want you to draw this little guy over and over and over again until you draw him perfectly. Because if you can draw him perfectly, guess what? You know the signs and symptoms of, and you know the side effects of any drug ending in -sone. So here's what it goes. Now this man is called Cushman. Okay, Cushman. Now, I'm going to draw a head, but don't draw the head real big because you need a really space for a really big body. Okay, so don't take up all your space with the head. Okay, the first thing on the head is you need to draw a moon face. Okay, he's got a moon face. And you say, oh, I can't draw. Okay, well, can you do this? That'll do it. Okay, so draw a moon face. Whatever your skill set is, just draw a moon face. Because that's the first symptom, moon face, puffy moon face. Then, draw a beard on him. What's the fancy term for excess hairiness on the body? Close. Hirsutism. Hirsutism. That means lots of hair. Hirsutism. Okay, next, draw a real big body, and I mean a big one. Put a bump on the front. Oh. And a bump on the back. Put a bump on the front and a bump on the back. Now, what's the bump Okay, let me ask you this first. What do we call the big round body? Obesity, but a certain type of obesity. Truncal or central obesity, they'll call it. Because see, your arms and legs aren't fat. It's just your body. Your arms and legs are actually really skinny. So it's truncal or central obesity. That's the big body. What's the bump on the front? No. No, the buffalo hump is the bump on the back. Because buffaloes have a bump on their back. So that's the buffalo hump right there. This is the gynecomastia. Gynecomastia. Those are female tight breasts on men. They sort of wear the bro. If you remember Seinfeld. So you have gynecomastia and buffalo hump, as well as the central obesity. Now, I want you to draw a skinny arms and skinny legs. Skinny arms, skinny legs. Because they have atrophy of those muscles. Those muscles waste away. All right, then I want you to fill him full of what? What's that? Water. So he's retaining what? Sodium and water. He's retaining sodium and water. So what's he losing? Out the back. What's he losing? Potassium. He's losing potassium. Okay, put some striae on him. What are striae? S-T-R-I-A-E. Stretch marks. He has these stretch marks on his abdomen, striae. Then, the most important one of all to remember, this is the most important one, put high glucose if you have room. High glucose. Because this causes them to be hyperglycemic. They look like diabetics. So if you're on a steroid and you're diabetic, talk to me. Diabetic, put on a steroid.
A lot of insulin.
What's that?
You need a lot of insulin.
You need more insulin because the steroid is going to increase the blood glucose and you're going to go out of control. What's that?
And you're immunosuppressed.
Yeah. Now I want you to put bruises all over him. Because what does he do real easily? He bruises extremely easily. We're almost done. We only have 2 things left. The last thing is I want you to make him say something. You know how they have those little cartoon speech balloons? Have him say something, and what he says is, I'm mad. I have an infection. I'm mad. I have an infection. Well, that tells you 2 things about him. What's the first thing it tells you? He's grouchy. He's irritable. And secondly, he's immunosuppressed. So if you ask me, Mark, what are the signs and symptoms of Cushing's syndrome, or what are the side effects of steroid meds, I would close my eyes. Why? I'd be picturing him and I'd say, okay, moon face, hirsutism, central obesity, gynecomastia, buffalo hump, retaining water and sodium, losing potassium, high glucose, wasting extremities, striae, bruising, irritability, and immunosuppression. And who did I describe? Cushman. I have this vision And I went down through and chung, 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 chung. Because you're going to see it. One of the famous ways that people ask it is they'll give a person with an acute exacerbation of COPD in which they need Solumedrol, a steroid IV push every 8 hours to reduce the inflammation in the airways. And it's a steroid. And they'll ask what nursing action needs to be taken when they're on this steroid. Accu-Chek's Q6. Because what do steroids make your sugar do? Go up even if you're not diabetic. And if you are diabetic, look out. Okay, so you got Cushman? I'm serious about drawing him because if you don't draw him and don't learn him, many of you in here are going to say, oh, nuts, when you get onto your test because you're going to wish you had. You're going to wish you had. Okay, now what's the treatment? Well, the question is, do you have too much or too little here? Too much. What's the classic treatment for hypersecretion of a gland? What's the number one treatment for a hypersecretory gland? Cut it out. So adrenalectomy. But what happens if you do a bilateral adrenalectomy, do you think? If you do a bilateral adrenalectomy. What does that mean? Do you have any adrenals left? So what do you have? Addison's. Okay, now think about it. Why did you do a bilateral adrenalectomy? What did you look like that made the doctor do a bilateral adrenalectomy? Looked like Cushman, right? So he did that to prevent that. But once you do that, you can induce what disease? Addison's, for which you give a steroid ending in "-sone, the side effects of which now make you look like Cushman, which is why you had the surgery. So it's really frustrating. I mean, it takes like a year or two to get them equilibrated back to where they're feeling normal. And that's the problem with endocrine surgery, is the endocrine surgery creates the opposite problem, for which you have to take the hormone, the side effects of which make you look like the thing you had in the first place. So think about, if you're hyperthyroid, high thyroid now, what's the major treatment? Thyroidectomy. And if you do a total thyroidectomy, what do you induce? Hypothyroid, for which you have to take thyroid pills. What are the side effects of thyroid pills? They look like Graves' disease, which is the reason you had the surgery in the first place. You see, any endocrine gland works that way. It's really frustrating to these poor people, and it takes years to get it back to normal. Okay, let's finish up. For today, we have probably 2 things to do and we'll be done. Let's talk about toys on page 33. Kids' toys. Children's toys. This is a lecture about selecting the appropriate play activity or toy given the age of the child, generally speaking. Now, when you select toys or play activities for children, there are usually 3 things to consider. I'm just going to walk over here, I'll keep talking. 3 things to consider. The first one, is it safe? The second one, is it age appropriate? Third one, is it feasible? You have to make sure that the toys you're using are safe, age appropriate, and feasible. Sorry, my back's killing me. I can't stand anymore. First thing, safety. Safety considerations when you're thinking of toys. There are 3 things you have to consider with safety of a toy. The first thing is, number 1, no small toys for children under 4. If you've got a 4-year-old kid or younger, you should not pick a toy that has small parts they could aspirate. If they're over 4, guess what? The small parts are just fine. So 4 is your cutoff age for small pieces, parts to toys. Second thing you consider for safety. Number 2, no metal, M-E-T-A-L, no metal toys if oxygen is in use. If they're getting oxygen. Why? Sparks. Does anybody know a fancy word they might use in place of metal? That means the same thing as metal? Die-cast. D-I-E-C-A-S-T. Die-cast. If they say a die-cast car, they're talking about one of those little metal matchbox thingies. And that's a no-no if oxygen is in use. Third safety consideration, number 3 safety consideration, and this is more vocabulary than anything. Write down, beware of fomites. F-O-M-I-T-E-S. Beware of fomites. Now you guys should be asking me, what in the world is a fomite? A fomite is a non-living object that harbors microorganisms. It has to be non-living, and it harbors microorganisms. By the way, just to see if you know your epidemiology, what do you call a living organism that
Vector.
harbors microorganisms?
Vector.
A vector or a host. But this is a non-living, so it is a fomite. Now, why in the world are we talking about fomites with kids?
Put it in their mouth.
Toys are notorious fomites in a pediatric ward. They stick them in their mouth. The next kid sticks it in their mouth. I mean, it's just really bad. So toys are horrible. Now, which toys make worse fomites than other toys? What toys are the worst fomites? Stuffed animals. What makes the best toy because it's unlikely to be a fomite? Hard plastic. What can you do with hard plastic toys that you cannot do with stuffed animals? You know, bleach them till they're dead. You know what I mean? You can terminally disinfect a hard plastic action figure. Okay? You can't terminally disinfect Tickle Me Elmo. All right? So if you have a child that is immunosuppressed, what would be the best toy for that child?
Hard plastic.
A hard plastic action figure. All right, those are the safety considerations. Feasibility just means could you do it? And it's pretty common sense. For example, can a 13-year-old, is swimming a good activity for a 13-year-old? Is it safe for a 13-year-old? Is it age appropriate for a 13-year-old? Is it feasible for a 13-year-old in a body cast? No. See, so feasibility can come into this too, but that's just going to be common sense. In other words, feasibility means could you actually play it with this child in the situation they're in? Okay, the next one is age appropriateness. This will take up the majority of the lecture because this is what they test mostly. Is they want to know if they give you a kid of a certain age, what toy should you give them? So let's start out with the first year of life, infancy. From 0 to 6 months of age, the best toy is a musical mobile. The best toy is a musical mobile. Because these kids are sensory motors. They are sensory motors. So the best toy is something that stimulates both motor and sensory. That's why the musical mobile is best. However, if the boards does not have musical mobile there, your second best answer is to look for something hard, meaning what? You know, something that can be distant. No, did I say hard?
Yeah.
It needs to be soft right now. but it has to be large. Why large?
They don't choke on
So
it.
they don't choke. Why soft? So they don't hurt themselves. What's the problem? Well, what the problem is, what do you do with a 3-month-old who is supposed to have soft toys if that 3-month-old is also immunosuppressed? You see the treatment problem there? Boards won't go there because that's a conflict of two principles. They're just happy you know the principles, period. So don't go there. But you do see the inherent problem in that, don't you? Okay. Now let's talk about the 6 to 9-monthers, the 6 to 9-month-olds. These kids are working on a skill called object permanence. Have you heard of object permanence? What does that mean? Yeah, the idea that it's still there even if you cannot see it. For example, if a child does not have object permanence, if I put their favorite toy under a blanket, what will they do? Cry. Because it's what? Gone. Into that, third dimension, that 8th dimension, never to be seen again. If a child has object permanence and you put their favorite toy under a blanket, what will they do? Rip off the blanket and grab the toy. You see, it's very different. Now, at 6 to 9 months of age, your play should be teaching them that. That is the big task they need to learn intellectually. So you should play with them with toys and activities that teach them object permanence. So the best toy is what I call a cover-uncover toy. Cover-uncover toy. Now, I cannot tell you exactly what toy they will use. Okay? But I can tell you what kind of toy you should select. So you should select for a 6 to 9er, you should select a toy where you cover it up and then you uncover it. Then you cover it up and then you uncover it. What is that teaching them? Object permanence. So could you give me some examples of cover-uncover toys? Jack in the Box. Those pop-up pals. Remember? You push the right button, then they pop up, then you push them down, then you pop up, and then you push them down. Those books that have the little windows, and then where are the birdies? Oh, there they are. Where are the birdies? Oh, there they are. Where's the birdies? There they are. And you're covering and uncovering the little picture of the birdies in the nest. That's perfect for this age group. Fantastic. Playing peekaboo. Why? You're there, then you're not. Then you're there, then you're not. That's good. Putting a blanket over your head and then uncovering your head and then putting a blanket over your head. That's really cool. That's good. And then what you do is they start laughing and then you stop doing it and see if they're learning. Because if they're learning, they'll pull the blanket off and laugh. If they don't, they'll go. Actually, do you guys know much about dogs? That's how you test a dog's intelligence. Because one of the highest order cognitive skills a dog can perform is object permanence. And if you throw a blanket over your dog and it just sits there like this, you got a dumb dog. If you throw the blanket over the dog and he goes, then you got a good dog. You got a smart dog. So you'll know how dumb your dog is tonight. Some of you are saying, I do that to my husband and he doesn't take off that. All right. Well, what's the second best toy if a cover-uncover toy does not show up? Something large, but it should be hard, firm. So you can make it of plastic, wood, metal. So how old does a child need to be before they're allowed to play with anything made of wood, metal, and hard plastic? At least 6 months of age. By the way, what is the worst toy in the world for a 6 to 9 month old kid? The absolute worst toy. The musical mobile. What was the best toy for a kid before 6 months? The musical mobile. What's the worst toy for a kid after 6 months? The musical mobile. Why? Because now they pull themselves up, they sit up, and they strangulate. Many, many kids have had strangulations or near strangulations from the musical mobiles that should have been taken out of the nursery months ago. Okay. The next age group are the 9 to 12 monthers, right? And these kids are working on vocalization. They're learning to speak. So what kind of toys are best for these kids? Speaking toys, talking toys, verbal toys. Now, I'm not going to give you a specific one because I don't know what they're going to test. But this is going to be like Woody the Cowboy, Teddy Ruxpin, Tickle Me Elmo, Slap Me Susie. I don't know them, all of them. They're just sort of, all those ones where you got a what? You got a string, and you pull the string, and it says something. That's really cool. See and Say, Barnyard Friends, the cow says moo. Fantastic for this age group. Talking toys. What kind of books? Talking books. Really good for this age group. If we just talked about books alone, what's a good book for a kid under 6 months? Soft booking and go what? Right? What's a good book for a kid 6 to 9er? Picked window books. What's the best book for a 9 to 12er? Speaking books, talking books. All right? The other thing about a 6 to 9er that's down here is purposeful activity with objects. Purposeful activity. In other words, how old does a child have to be before they'll do anything purposeful with a toy? At least 9 months. So let me ask you this. Could a 7-month-old play with 3 wooden blocks? Could they play with 3 wooden blocks? Is wood okay? Because they're over 6 months, they could play with 3 wooden blocks. Could a 7-month-old build a tower of 3 wooden blocks? Why? Why no? Build is a purpose word. And you cannot pick any answers that have purpose words in them until the child is at least how old? 9 months. So here's the deal. Never pick answers with the following words in it if the kid is under 9 months. Never pick an answer with the following words in it if the kid is under 9 months. So here are those words. Build, sort, stack, make, construct. Why? Those are purpose words, and a kid does nothing purposeful before age 9 months. I tell people, a baby's in the womb how long? 9 months, and it's another 9 months after they're out till they do anything purposeful. Prior to that, it's all random. Okay, let's talk about the toddlers, which are the 1 to 3-year-olds. They are, the best toy for them is a push-pull toy. Something that you push, something that you pull. Now, I don't know what it's going to be, but give me some examples of push-pull toys. The lawnmower, the wagon, the buggy, that stupid popcorn poppery thing. What else? Yeah, baby strollers. The little dog with the floppy feet that you drag behind you. So anything that they push, anything that they pull, fantastic for 1 to 3-year-olds. Work on the gross motor skills. Work on gross motor, which is running, jumping. I always say, if it takes finger dexterity, no for the toddler. If you're sitting there thinking, now which of these activities could a toddler do? If any of those activities take finger dexterity, do not choose it for the toddler. Toddlers do not have finger dexterity. So could they use colored pencils? No. Scissors? No. Not even blunt scissors they can't use. So anything that requires finger dexterity is no for the toddler. The interesting thing is, people have misnamed finger painting. Finger painting is not finger painting. Finger painting is hand painting. Can toddlers do finger painting? Yes, because it takes your hand, not your... Do you ever see a toddler go... Yeah, with their fingers? No, they go... So it's hand painting, not finger painting, okay? So can they do anything that takes finger dexterity?
No.
No. But they can do finger painting, because finger painting isn't finger painting, it's hand painting. That's where people get confused. Does that make sense? Okay. They're characterized by parallel play. Parallel, which means you play alongside but not with. You play alongside but not with. Okay, let's talk about preschoolers, the next age group, the preschoolers. Work on their fine motor. So what do you pull out now? Things that take
Pencils.
what? Finger dexterity. So you need to, preschool is the finger dexterity. Number 2, work on their balance. So tricycles, tumbling class, dance class, ice skates, those are okay at this age. Don't put your toddler in dance class, gymnastics class, and hockey class. It's not going to work. When they turn preschool, they'll learn in 2 weeks everything they would have learned in 2 years as a toddler. So it's a waste of your money. Yes?
What about swimming lessons?
Swimming is different because that's more gross motor. In some sense, it doesn't really depend on balance. So infants should actually be taken for swim lessons because of safety issues. So an infant should be taught how to swim, at least know how to be used to being in the water, at least, so that it's not a, I would say probably, I don't know what age. Anybody know the age where swimming is?
It starts in 3 months.
0 to 3? I was going to say as soon as you want.
You can get them in.
That's what I
The
thought.
water, it's a parent-teacher class until they're in preschool. And
Yeah.
then once they hit preschool, then they're on
Then
their
they're on
own
their own,
group
yeah.
class.
But I don't think there's any lower limit. I think, like you said, 0 is what I know. Okay. What else? Okay, they are characterized. Work on balance. They're characterized by cooperative play. Cooperative play, which means what?
Play together.
As opposed to parallel. Parallel plays alongside but not with. Cooperative plays with. So they play with each other in groups. They interact and play together. And lastly, they like to pretend. They are highly imaginative. That their pretend play is big. You be the sheriff, I'll be the saloon keeper, you be the barmaid, I'll be the outlaw, and you all role play. I grew up in Youngstown, Ohio. I always got to be the Pope. Role play. I was the one with the wagon, so I got to be the Pope. Okay, I know you care. Okay, the next age group is the school age. And the school age kids are characterized by the 3 C's. They are creative. In other words, let them make it. Don't you make it and give it to them. In other words, would it be good to give them a coloring book and crayons? What would be better? Blank paper and colored pencils, because then they can create their own pictures rather than fill in the blanks, you know. Would you give them plastic cookies, plastic lemonade, and plastic donuts and have them have a tea party? No. Could they have a tea party? Yes, but what would you do with a school age? They make the what? Cookies. They make the lemonade. They make the muffins, and they have a, you see what I'm saying? That's why Legos is such a good toy for this age group. Why? They're building and making, they're creating. You don't give them trucks and cars, and you give them things that they make into cars and trucks and that kind of thing. That's why Transformers is good, because it makes the creativity and all. Okay, second C, they are collective. They're always collecting something. Beanie Babies, Pogs, Digimon, Pokemon, Webkins. What was the stupid one this Christmas? Zuzu Pets. Yeah, Zuzu Pets. You know, all that kind of stuff. And don't the toy manufacturers know this? Oh yeah. Remember about 5 years ago, of course I had girls. So 5 years, 6 years ago, Mattel came out with Barbie and the not 2, not 4, not 6, not 8, not 10, but 12 dancing princesses. Because they knew that all the little girls would want what? All 12, so why would you give Barbie and the 2 dancing princesses? I mean, that's stupid. What a bad marketing plan. You know, go 12, you know, they'll buy them. So, you know, that's toys. They know all this stuff. And last C, they are competitive, which means they like to play games where there's a winner and a loser. Now, they don't like being the loser. I never said that. But I'm saying that if you go over here to the 5th grade, to the nearest elementary school, and you tell them, we're going to play a game, what do they say? Yeah, cool, get out of school, play a game, cool. But if I tell those 5th graders, guess what? Everybody's gonna win. Nobody's gonna lose. We're all gonna get the same prize. What will they say? Stupid game. Just give me the dumb prize and don't waste my time. But if I tell them, hey, we're gonna play a game, $400 and a bike for the kid that wins. Oh my goodness, I'll have those kids doing all, tipping cows, you know. They'll be doing everything. So they like competition. Now what about preschool? Make a statement about competition in preschool. No, not unless you want a room full of screaming, crying kids. Who wins in preschool? And what do they get? The same prize. And I'm talking the same prize. Don't go in with orange lollipops and grape lollipops. Go in with one size, one flavor, and if they don't like it, they don't get it. Don't go in with 2. You're going to have a Chernobyl. Forget about it. Adolescents, what's their play? Peer group association. Peer group association. They want to what?
Hang out with their friends.
Hang out with their friends. So do they do much?
Sleep.
Have you ever seen a group of teenagers? I have girls, so I'm suspicious as a father. So I built a rec room on our house so that the pool table and the TV and everything would be at whose house? Ours, so that all the people would come to our house so I could keep a little, I didn't tell about the closed circuit television in the, you know, no. But they would all come over to our house, you know, 20 of them. And guess what they'd do? 20 of them. So I'd go in the room and I'd say, How about if we play polo? Dad, get out here. Get out here. Well, how about if we watch a movie? Dad. So for 4 hours. You know, and I go in and here's my daughter texting. And I say, Emily, who are you texting? Bethany. Bethany who? Bethany Wales. Emily, Bethany's sitting right over there. Yeah, I know. They're texting each other in the same room with all these boring teachers doing nothing. I know, I'm old, forget it. But they just hang out. Now, what's that got to do with nursing? Here's the deal. If they gave you a question where a gang of teenagers, 5, 6, 7, 8 of them, were hanging out in one teenager's room, what do? Do you let them or not let them?
Let them.
You let them, unless one of 3 conditions is happening. Here are the 3 things that would, well, no, not what you're thinking. Unless one of these 3 things is true, you let them hang out. The first thing is, if anyone is fresh post-op. In other words, if any one of those teenagers, adolescents, is less than 12 hours out of surgery, they shouldn't be hanging out. Okay? Second thing, if anyone is immunosuppressed, they shouldn't be, for obvious reasons, correct? And thirdly, if anyone has a contagious disease. So if you've got 13 kids hanging out in one room, unless somebody is fresh post-op, somebody is contagious, or somebody is immunosuppressed, let them hang out. Get over your control issues. Let them hang out. All right? Let's do the last lecture of the day, laminectomy. Laminectomy. What page? 38. I'm not going to do lab values at this time of day. Your brain will go totally fried. Laminectomy. Lamina are the vertebral spinous processes, and ectomy means removal. So laminectomy. Ectomy means removal, and the lamina are the vertebral spinous processes. Vertebral spinous processes. Now, what are the vertebral spinous processes? Well, let me ask you this. Have you ever felt the bumpy bones on the back of somebody? You're not really feeling the body of the vertebrae. You're feeling those wingy thingies out the back. Those are the lamina. So in a laminectomy, do I remove the round bodies of the vertebrae? No, you'd be an invertebrate if I did. That wouldn't be good. What I'm removing is those wing things out the back. I remove those. So we're just removing the posterior processes of the vertebral bones. Just part of it. Now the question is, why in the world would you do that? What's the reason for a laminectomy? The reason is to relieve nerve root compression. To relieve nerve root compression. Because sometimes when the nerve roots come out of the spinal cord, there's like calcium or herniated discs or inflammatory masses pressing on them, and that causes problems. So we cut away that bone to give the nerve more room to exit. So it relieves the compression on the nerve root. Well then, what are the signs and symptoms of nerve root compression? The 3 P's. Pain, paresthesia, which means what? Numbness and tingling. And paresis, which is muscle weakness. Pain, paresthesia, and paresis. Those are the 3 signs that your nerve roots are being pressed upon, for which we would do a laminectomy to remove those back bony parts so that your nerve roots can come out real nicely and not be pressed on. Now, when you get a laminectomy question, the most important thing to pay attention to is the most important thing that you pay attention to in any neuro question. Does anyone know what the most important thing to pay attention to in any neuro question is? Location. It is location. If you want to get a neuro question correct, pay attention to the location of the problem, because the location will determine the symptoms. The location will determine the prognosis. The location will determine the treatment. Location is everything in neuro. There are 3 locations for laminectomies. They are cervical, thoracic, and lumbar. Cervical, thoracic, and lumbar. Cervical means the neck, thoracic means the upper back, and lumbar means the lower back. Now, in the rest of this page, I'm going to illustrate for you how, when you change the location, you change the answer to the question. So let's talk about it. Is the next one F or E?
E.
E. Letter E. What is the most important pre-op assessment for a cervical laminectomy? What's the most important word in that question?
Cervical.
Cervical. Okay, so the cervical spinal cord innervates 2 things: diaphragm and arms. Diaphragm and arms. That's what your cervical innervates. So, if you are doing a pre-op assessment for a patient going for a cervical laminectomy, what is the most important thing you would check out before surgery? What? Breathing. Why? Cervical innervates the diaphragm. So breathing is number 1. Check out their breathing. How are they breathing? Number 2, if that is not there, if breathing isn't there, the next best answer is the function of their arms and hands. That would be your backup answer. So what's number 1 answer for cervical? Breathing. What's number 2 answer for cervical? Arm and hand function. However, letter F, what did I change in the question?
Correct.
Location. I changed it from cervical to thoracic. And when I changed location, I changed the answer. It is no longer breathing and arms and hands. For thoracic, the most important assessment is the cough and the bowels. Cough mechanism and bowels. Cough and bowels. So what would be the most important thing to assess before a thoracic surgery? How well the patient coughs. Not so much gag, but how they cough. So what I want you to do is this. I want to illustrate how this is. Your thoracic spinal cord innervates your abdominal muscles and your gut muscles. So what I want to do is I want you to do this. I want you to put your hand on your abdomen, on your abdominal muscles. I want you to cover your mouth, and I want you, on my signal, I want you to cough. And when you cough, I want you to feel what happens here underneath your hand. Okay, ready? Cough. How many felt a contraction? Great. Okay, now, I'm going to give all of you a thoracic spinal cord injury. Okay? Okay, you got it. So now you can no longer contract what? Your abdominal muscles. So relax them. Relax them. You're paralyzed. There. You cannot contract those muscles. You're paralyzed. Okay, now, put your hand on your abdomen. They're paralyzed. Cover your mouth. And this time on my signal, I want you to cough. But don't you dare contract these muscles, because you're not allowed to, because you're paralyzed there. Okay, ready? Cough. Wow, some of you actually got a good cough out. Usually that's impossible. Somebody has to be cheating. No, but do you understand? So in order to cough, what do you have to be able to do? Contract these muscles. And if you can't contract these muscles, you cannot cough. You can go, but you can't cough. Can you breathe? You can breathe, but you cannot cough. So what assessments do you have to make for a thoracic? Coughing and bowel sounds, right? All right, but what about G? What did I change in G? The location. And when I changed the location, I changed the answer. The lumbar innervates the bladder and the legs. Bladder and legs. So what's the most important assessment before lumbar laminectomy? Yeah, when was the last time they voided? Is their bladder distended? Or is it empty? You need to know that before surgery. And then, if that's not there, what's the backup answer? Function of arms and legs. So that's important, knowing that. So cervical is what? Cervical is
Diaphragm and
breathing and arms. Thoracic is coughing and bowel. Lumbar is bladder and legs. Okay, let's turn the page and talk about post-op laminectomy. The number one post-op answer on NCLEX for laminectomy is log roll. If you have a question that says log roll your patient and it has anything to do with spinal cord, including laminectomy, what's your top answer?
log roll.
Log roll. You always pick log roll if it's there. You cannot go wrong by picking log roll. Now, in addition to knowing that, there are 3 other things you need to know about mobilizing clients after spinal surgery. Number 1, do not dangle these people. Do not dangle them. Now, dangle does not mean to hold them by their ankles out the window. What does dangle mean? Sit on the edge of the bed, which is what we do for everybody. Isn't that the first thing we do for all post-ops? Dangle them. What am I telling you about these people? Don't do that. Go from lying down immediately to what? Walking around. None of this dangle business. Now, can they sit on the edge of the bed long enough to overcome orthostatic hypotension? Sure, but they shouldn't sit there for 10, 15 minutes dangling. Yes?
So will it be specified as like feet flat on ground, sitting on edge of bed?
Sitting on edge of bed with feet flat on ground is not appropriate for a fresh post-op laminectomy. If they say sitting at the side of the bed long enough to overcome orthostatic hypotension, then it's okay for a laminectomy. But if they say sitting with the feet on the ground, sitting with the feet not on the ground, dangling, none of that for a lamb. Sitting is a horrible position for a lamb. Okay, number 2 restriction. Do not sit for longer than 30 minutes. They're not allowed to sit for longer than 30 minutes. So what kind of typical post-op order would you question with a laminectomy? What typical post-op order would you question with a laminectomy? Up in chair for 1 hour, TID. Isn't that real common? Up in chair for 2 hours, TID. Real common. Up in chair for meals is really not bad. Because how long does a meal usually last? About a half hour. So that's not bad. Because they would say up in chair for meals is good because you're only up for a half hour. So they'd say that's okay. Third thing, they may walk, stand, and lie down without restrictions. They may walk, stand, and lie down without restriction. So there's only a restriction on what position? Sitting. All the OSHA studies since 1970s have proven what is the one hospital worker position designation that has the highest incidence of back injuries. What worker in the hospital has the highest risk of back injuries? Not nurses. Not nurse aides. Admitting clerks. Because what do they do all day? Sit. And that's worse than lifting and slugging 200-pounders in the bed. It's worse for you. It's terrible. So sitting is horrid position for your back. Okay, let's talk about post-op complications. What will the post-op complications depend on? Location. So what would be the number one post-op complication after a cervical laminectomy? But breathing is not a complication. It's a good thing. They won't breathe very well and very deeply after surgery. They will have trouble breathing deeply after surgery. What will develop? Pneumonia. Yes, pneumonia is the #1 complication. Why? Because they don't breathe so well. Why? Because it's a cervical, and cervicals don't breathe so well after the surgery. Because that's the location that hits the lungs. Okay, well, what if they change it to a thoracic? The post-op complication after thoracic, what would it be? Well, what won't they do so well? Cough. So what will they get then? Pneumonia. And they'll have an ileus because their bowels won't work. But what's the #1 problem after a lumbar laminectomy? Urinary retention, followed by problems with the legs. Do you see where they could trick you? And they could say, a person underwent a lumbar laminectomy 10 hours ago. What's the #1 problem? A, airway, B, breathing, C, circulation, D, urinary retention. What would be the answer? Urinary retention. Because they don't have A and B and C problems because it doesn't affect them. You see? So that's not what they would do. Let me ask you this. You are caring for a patient with a lumbar oligodendrogliosarcoma. What is the #1 problem? A, airway. B, ileus. C, cardiac arrhythmia. D, urinary retention. What would be the answer? D. Because it's a what? Lumbar. And it doesn't matter what it is. You don't have to even know what this is. This does not determine your answer. What determines your answer? Location does. So all you have to do is, if you know that cervical is breathing and arms, thoracic is cough and bowels, and lumbar is bladder and legs, you got the whole thing. Because all you have to do is look at the location, because the pathology doesn't matter. Could I put a lumbar abscess? And wouldn't it be the same thing? Lumbar surgery, same thing. Lumbar spinal cord injury, same thing. Lumbar ependymoma, same thing. So what determines pathology in neuro? Location, which makes it actually easier. Okay? Okay, next thing. Typically we don't have chest tubes with laminectomies, but the anterior thoracic will have chest tubes. Letter C. Letter C, the anterior thoracic will have chest tubes. What does anterior thoracic mean? Anterior. From the front, through the chest, you go to the spine. Well, if you get to the spine through the front of the thorax, you're going to have a pneumohemothorax and need chest tubes, right? Okay. Number 5, laminectomy with fusion, and the key word here is with fusion. That means they take a bone graft from the iliac crest. So laminectomy with fusion involves taking a bone graft from the iliac crest. Here's what they do with this one. Here's your vertebrae. Here's your vertebrae. Here's your disc. If they take the disc out, you cannot have bone on bone. So they have to take some bone from your hip, bring it over here, put it in between these, and fuse it so that you don't have that grinding. So this is a laminectomy with fusion. Not all laminectomies have fusion. Most laminectomies don't. In most laminectomies, all you're taking off is this wing thing out the back. and you're not messing with the disc. But if you remove the disc, then you got to do a fusion. And you got to get bone from somewhere, and one place we get it is from the patient's own hip. So if you have a laminectomy with fusion, how many incisions will the patient have? 2. One where? Hip, and one on the spine. So turn the page. Of those 2 incisions, which one will have the most pain? The hip will. Believe me, that hurts. Which one has the most bleeding and drainage? The hip. That's where the hemovac will be. That's where the JP will be. Which one has the highest risk for infection? Actually, they're equal. They have a 50-50 chance of infection. And which one has the highest risk for rejection? The spine. So if you look at the 2 incisions post-operatively, which one causes the most problems? Which one causes the most problems? The hip does. So surgeons are wanting to get rid of that hip incision. Why do the surgeons want to get rid of that hip incision? Because it's shorter recovery, a lot better, no problems, cuts the infection rate in half, decreases the drainage by 80%, decreases the pain by 80%. A lot better all the way around. Hospitals love it because they get money for shorter stay, they make more profit. That's why here it says surgeons are using cadaver bone from bone banks. Why? Yeah, because if they're going to cut this disc out, they can take bone from a dead person, put it in between your bones and fuse it, and there's not that second incision. So they use that quite a bit. There is a slight increased risk of rejection, but not that bad because bone is not protein, and protein is what triggers the antigen antibody response, the immune response. Nowadays, they're even moving away from cadaver bone to guess what? Synthetic bonding substances that we are developing in the lab. But that's not on boards yet. Okay, discharge teaching. Is this important? Oh yeah. Discharge teaching, very, very important. There are 4 temporary restrictions and 3 permanent ones after laminectomies. The first temporary, do not sit for longer than 30 minutes. How long do you think that restriction applies? How many weeks? 6 weeks. If you have to guess how long something should be restricted and you do not know, you should always pick 6 weeks because that will pay off for you. If you know how long to restrict it, then pick that. But if you don't, pick 6 weeks. You'll be surprised at how well that pays off. Number 2, lie flat and log roll for 6 weeks. Now that doesn't mean you have to actually do it for 6 weeks continuously. That just means when you do turn, log roll and do lie flat for that 6-week period of time. Number 2, no driving for 6 weeks. And do not lift more than 5 pounds for 6 weeks. And how heavy what common household object is about 5 pounds? Gallon of milk. I know a lady that had back surgery, laminectomy, when her infant was like 9 months old. And that was disaster. Why? She couldn't pick him up, and what does a 9-month-old always want? Picked up. That kid learned to walk real fast. I mean, that kid was walking at 10 months. I go, whoa! Well, necessity is the mother of invention, So that kid really learned. Permanent restrictions. Laminectomy patients will never be allowed to lift objects by bending at the waist. How should they lift objects? Lift with the knees. Well, everybody should be that way, right? Should anybody do this? You should all do it with your knees. That way you get bilateral knee replacements instead of a laminectomy. Second thing, Cervical lambs are not allowed to lift anything over their head. Nothing goes over your head with a cervical lamb for the rest of your life. So can a cervical lamb do this?
Yeah.
This? Yes.
Yeah.
That? No, not even with a feather. So they need step stools in their house. And then no off-trail biking, jerky amusement park rides, or horseback riding for obvious reasons. You know, the percussion stuff. So that's laminectomy. But understand, this lecture on laminectomy can be used to get any spinal cord questions correct. Correct? Isn't that true? Because you're going to pay attention to what? Location. And that's where it's going to pay off. Okay, tomorrow for the last day. And I think, let me see, we covered 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 16. We did 18 already, and we have 1, 2, 8 to go, right? Is it 8 to go? And we did probably 10 today. So we have less to do tomorrow than we did today. So we'll see you tomorrow. And we've not even been together for more than 24 hours. That's amazing. Any laminectomy. I know. And that's why, but this is what the books, so you have to go with what the book says, and this is book stuff. There is usually ileus and pneumonia.
Oh, God, I'm running.
Because coughing and bowels. The thoracic is always about coughing and bowels.
With this, does
Coughing and
the
bowels.
horse test the Erickson's stages of development?
Yes, and that's
number 2?
It's in the blue book, so tie this to this.
Tie this to that. Yeah, it's sort of built on it, but not built on it. This is more built on cognitive ability, more Piaget, whereas because Erickson is psychosocial development, toys are a lot more cognitive.
Number B?
Your ability to play a game of toys is more
Ileus
your
and
cognitive
pneumonia, which he said
development than your
means coughing and
psychological
bowels.
development.
So
Look at
it's
that.
study for the complex complete that's here and the blue book.
Yes, that blue book is so essential. I can't stress it enough that book is learning the stuff that only you can do. I can't learn it for you. You just have to put in the time to learn it. And I know a lot of people just go, but you know, that's the way it goes. Because if you put in the time, it'll pay off.
Okay, thank you.
And pneumonia, coughing and bowels, urinary and leg problems, and then pneumonia after cervical, watch for pneumonia. Oh, but anyways, we could always recheck.
Yeah.